Good morning, everybody. I'm Dr. Michael Atkins, the Deputy Director of the Georgetown Lombardi Comprehensive Cancer Center and a researcher and clinician treating patients with melanoma. And I'm here with my colleagues to launch this MRF-sponsored program entitled Together Against Melanoma, a patient and caregiver symposium focusing on research and education, hope, and healing. This is going to be brought to you by members of the Georgetown Lombardi Comprehensive Cancer Center, one of about 50 NCI designated cancer centers in the United States and the only one in the nation's capital in DC, together with MedStar Health, the Lombardi Cancer Center's clinical partner and the largest care provider in the Mid-Atlantic region. We really had hoped to be able to do this program in person, have a chance to meet with patients and their caregivers and their families, and be able to talk about their concerns and answer their questions. But with the changes brought on by the pandemic and the availability of things like Zoom, we're finding that's harder and harder to bring larger numbers together. And so in the end, we decided it was better for all, rather than doing a hybrid program, to do it all virtually. But hopefully you all will stay through the whole program, have a chance to ask questions via the chat, and have your questions answered during our panel discussion. There have been tremendous changes in the care and outcome for patients with melanoma over the past decade and a half, and you're going to hear about those changes all the way from the very beginning in terms of prevention activities to the role of surgery, the role of dermatology, and the treatment for patients with high-risk disease, metastatic disease, and also some of the things that are coming in the future. And they're going to be brought to you by part of our caregiving team that's really been involved in not only treating patients, but doing research that has advanced this field. So I think it'll be a very interesting program. And I, once again, encourage you to stay through it. I'm going to stop there and turn this over to Kylie Lapira, who is the Melanoma Research Foundation's Chief Executive Officer, a position she's held since January 2017. In her previous role, she was Chief Development Officer, and she led the foundation's development program and worked with donors and their families to make charitable donations to significantly impact melanoma research, education, and advocacy. And she's going to tell you about a little bit more about the Melanoma Research Foundation and what it's doing in the areas of supporting research, education, and advocacy. Kylie?
Thank you so much, Dr. Atkins, and thank you all for joining us today. Dr. Atkins is also the co-chair of our Scientific Advisory Committee and really helps us lead our research and science program. So we're really grateful to have his leadership and his support of our work. I would like to give you all a little background on the Melanoma Research Foundation before we kick things off today and highlight some of the resources that we have at the foundation that are available for patients and their loved ones. So before I start, I just want to thank our sponsors. We have many different companies that support our education work, and we're so grateful. This enables us to provide all of our education offerings at no cost, which really helps us support the wider melanoma community. So to give a little background on the Melanoma Research Foundation, we were founded 28 years ago by a patient. She was dealing with her third recurrence of metastatic melanoma. And at that time, there were very few treatment options available. In fact, at that time, there were only 3 FDA approved treatments. And it was because of her advocacy and passion that she gathered her friends and family and started fundraising to enable research in this space. And over the years, we grew. We started off solely funding research in 1996, but as more FDA-approved treatments came to market and the hope in the field and the great people who were working on better treatment options got together, there was more funding available. And today, the funding landscape and the approval landscape is completely different than it was 28 years ago. And you're going to hear a lot about that really great information later today. So today, our mission is not only to eradicate melanoma by accelerating medical research, but we are also dedicated to educating the community about melanoma treatment options, as well as advocating for the melanoma community. And I'm going to tell you a little bit more about our tripartite mission in a moment. So many people ask, where is the MRF? Well, we are based in Washington, D.C., but we are a national organization. So we have advocates and communities all across the United States getting involved with our work, whether that be attending a 5K walk run, attending our annual Hill Day on Capitol Hill, hosting an event in their own community, or getting together like we are today for a patient symposium. So I'm going to touch a little bit on each pillar of our mission. I'm going to start off with research. So our research program involves a few things. First, we give grants. So what does that mean? We provide research funding to academic centers all across the United States. And as I mentioned earlier, Dr. Atkins is a part of that. So reviewing and scoring our grants to fund the best science. So to date, we have funded over $25 million in peer-reviewed research grants. And those have really spanned the continuum from medical students all the way up to senior investigators and to team awards. We also involve our advocates. So that means you. We involve you in our grant review process. So I would encourage anyone who might be interested in reviewing a grant to visit our website and sign up. We provide a training. You would not be going in blind, but we really want to involve patients and caregivers in our grant review process. We also host scientific meetings and workshops in very specific topic areas. So to give you an idea, we've hosted multiple symposiums or workshops in brain metastases. And this year we're hosting one in NRAS melanoma. And the reason we do this is really to bring together the field, to foster collaboration, foster new ideas, and really put a focus on some of the major scientific problems that are facing melanoma patients. The second part of our mission is education, and I'm actually going to hand it over to my colleague, Debbie, who's going to walk through our education program. Debbie?
Thank you, Kylie. Hello, I'm Debbie Turgai. I'm the Education Program Manager at the MRF. And I'm just going to go through a few of our educational offerings. We take our education very seriously. We have a lot of offerings for not just patients, but for caregivers and family members and providers. Sorry, could you skip back to the one slide? Our educational offerings, which I'm going to go through in the next few slides, include educational materials, webinars, animated patient videos, patient and caregiver symposia series, which we're here today. And then we have a lot of offerings on rare subtypes. Where do you find all this information? If you go to our website and you go to our Educational Institute, you'll find our learning platform, all of our education materials, and our animated patient videos. This is a snapshot of some of our educational offerings. We have over 26 pieces of literature. Topics include cutaneous, OM, mucosal, youth prevention, pediatric clinical trials. All of these are free to download, and we also send these to physician offices all over the country, so you may have seen some of them even in your own dermatology office. And this is just more examples of our educational literature. I'm super proud of our literature. It's very professionally done. It's easy to understand. And we, again, free to download on our website for anyone who is interested, and also we will send you materials if you're having an event and you want to share the information with others. So our animated patient videos, we currently have 6 learning modules. These are great videos. I always recommend these for family members who want to learn a little bit more about melanoma. All of these videos are less than 10 minutes long. In fact, the longest one is about 7 minutes. So most of them are about 5 minutes long. They're packed with a lot of amazing information for patients, caregivers, family members, anyone interested in learning more. And then our learning platform right now has it has 65 on-demand videos, because I just uploaded a new one the other day. These include past patient and caregiver symposia. So if you want to see any of our past symposias, you can find them here. We also host webinars once a month, so those you can also find here, and our melanoma educator course. As I just mentioned, we host an Ask the Expert webinar series once a month. These are on current topics or topics that patients want to know more about. Each webinar, we have an expert, but we also include a patient so we can get that patient voice. You can find all of these webinars on our learning platform, but also on our YouTube page. And if there are any patients out there who are interested in participating in sharing your story, please reach out to me, because we're always looking for patients to share their stories. And lastly, we have a patient and community forum. This is an amazing avenue if you have questions that you want to talk to about with other patients. Topics include TIL cell therapy, newly diagnosed, bereavement support, melanoma, skin of color, pediatric and AYA, caregiver support, and so much more. This is a really great platform for you to talk to other patients and caregivers and understand what you're going through together.
Great. Thank you so much, Debbie. And I'll also mention, in addition to the patient forum, in terms of support, we also have an oncology nurse on staff who answers questions and is there to help navigate. You can reach her at askanurse@melanoma.org, and she will reach out and respond within 24 hours and help you with any questions or resources you may need. So thank you so much. Moving on to advocacy, which is the third pillar of our mission. And this is another great way for patients and caregivers to get involved. Every March, we go to the Hill and we talk to lawmakers about issues and legislation that they can sign on to that will directly benefit melanoma patients and their loved ones. Again, a really fantastic way to share your story and help move the needle for all melanoma patients. We also provide comments to regulatory and legislative policymakers on a very regular basis. And again, we mobilize our community around these issues. So if you are interested in advocacy and ways to get involved, I really encourage you to visit our website and sign up for our advocacy newsletter and connect on some of these issues. We also convene a global melanoma coalition, which are advocacy groups, organizations from all over the globe, and we bring them together to collectively advocate for access to treatments and different access points. So again, lots of things happening in our advocacy space. The main issues we rally around on are prevention. So prevention of melanoma, access to treatments, access to clinical trials, educating advocates, and funding. And that funding comes through the DoD, the NCI, and the NIH. And it's very exciting because $40 million of research is funded every single year through the Department of Defense, specifically for melanoma. And that's all because of our advocates really rallying around the need for melanoma research and funding. So I wanted to talk a little bit about our prevention and awareness campaigns. We just finished May, Melanoma Awareness Month. So many people probably saw a lot of messaging that we were doing trying to create awareness about melanoma. Our flagship campaign is #GetNaked. The goal of this campaign is to really get people to know their own skin and check their own skin, understanding what melanoma looks like, understanding if something changes, and getting to a dermatologist to get it looked at. So really advocating for themselves and learning how to do a self-skin check is really vitally important. We also have campaigns for the rare subtypes. We have a mucosal melanoma awareness campaign, as well as an ocular melanoma awareness campaign, as well as a pediatric melanoma awareness campaign. And that campaign is specifically geared towards pediatricians and parents. A few just cutting edge programs I wanted to mention before we wrap up here. We have a wonderful registry in ocular melanoma. So for any ocular melanoma patients who are tuning in today, we encourage you to visit Vision, which is our registry platform. This is a patient-reported registry where you're putting in your own information with the goal that collectively, especially with a rare disease, we'll be able to get enough data that will also help inform research. We also have a mucosal melanoma program, which is fantastic for people with this very rare form of melanoma. We're currently working on a mucosal melanoma patient and caregiver guide, and we held our first ever mucosal melanoma research and patient meeting back in December of 2022. Lastly, we have a very unique research initiative called our Breakthrough Consortium. This is 23 melanoma centers of excellence across the United States, where we foster collaborative efforts to advance research. So many of them are working on research projects, and they present once a year at ASCO, which is the big scientific meeting that happens once a year. So with that, I just wanted to share a few ways to connect with us. Here are all of our social media handles. Again, we encourage you to follow us on social media so you can really stay up to date on a lot of the different programming offerings we have and ways that you can engage. And if you want to get more involved and support our work, there are a variety of ways you can do so. We have our National Miles for Melanoma 5K Run Walk series. Actually, today we're in Denver doing a Miles for Melanoma walk. We have 2 galas in Denver and in New York. As well, you can do your own event. We have many people who host their own community fundraisers in their community to create awareness about melanoma, raise money for research, education, and advocacy, and really act as a beacon for knowledge in the melanoma space, which pays it forward in so many ways and helps educate so many more people about this disease. So with that, I want to again thank our sponsors, and I am going to turn it back over to Dr. Atkins, who is going to lead us into our first session of the day. So thank you so much. Over to you, Dr. Atkins.
Thank you, Kylie and Debbie. That's great description of the MRF. It's really a wonderful organization, which I've been had the privilege of being involved with in all different areas, including on the board of directors for the past 10 years or more. And it's really contributing to the great progress that we're making in all aspects of melanoma management. As we get into our presentations, I just want to encourage people listening to put any questions that you have as the speakers are going through their talks into the chat, and we'll try to address them during the panel discussion at the end of the first group of speakers, and then there'll be a second one at the end of the second group of speakers. So our first speaker is Dr. Etsup Ajibo, and she's a board-certified dermatologist in the Department of Dermatology at MedStar Health and assistant professor at Georgetown University School of Medicine. She obtained her medical degree at the Medical College of Georgia, and that's part of Augusta University in Augusta, Georgia, where she completed an internal medicine internship and dermatology residency. And her clinical interests include pigmented lesions, melanoma, non-melanoma skin cancers. And we've been delighted to have her as part of our program. our melanoma and skin cancer program at Georgetown and MedStar over the past year. And she's going to talk to you about melanoma risk factors. Go ahead.
Thank you, Dr. Atkins. Thank you for the introduction and for inviting me to this talk. I'm going to share my screen.
It's perfect.
Great. Excellent. Okay. So I have no conflict of interest, and I'm going to start out with a couple of cases before we start talking about melanoma risk factors. So the first case is about a 70-year-old woman with no personal or family history of skin cancer who presented to clinic with complaint of a lesion on her forehead that started about a couple of months ago, and she had associated occasional itching. I looked at the lesion. Clinically, it looked like tan-colored stachon papule, and under dermoscopy, it had a benign feature, and it was consistent with seborrheic keratosis. So I went ahead, because it was symptomatic, I treated her with cryotherapy. Then I started asking her if she has had history of sunburn and tanning bed use, and when was the last time she had a full body skin check. She said she hasn't had a full body skin check for over 4 years. So I offered her full body skin check and she agreed. So as I started the exam, I noticed about a 1.3 centimeter lesion on her chest. She stated that the lesion had been there for over 10 years, and it was seen by her physician 4 years ago, and she was told it was benign. And she reported a history of extensive sun exposure and sunburn during childhood, but she denied having history of tanning bed use. So this is a clinical picture of the lesion. Clinically, you can see lighter brown and darker brown areas at the periphery with central grayish discoloration. So whenever we see pigmented lesions, we use a special device called dermatoscope. You can see that on the right-hand side up here. And a dermatoscope is a handheld microscope that is equipped with a magnification lens and a light source. And this dermatoscope helps us to evaluate the morphology of a lesion by revealing its colors and structures that are not normally visible with the naked eye. You can see in this dermoscopy picture multiple colors, including dark brown, light brown areas, gray areas, and pink areas. You can also see atypical pigment network and areas of regression. These features are concerning for melanoma. So I took a deep shave biopsy, and the result came back as melanoma in situ. Then this is a second case. This is a 48-year-old woman with history of hidradenitis, but no skin cancer history, who presented to clinic for hidradenitis and management and full body skin check. Her family history was significant for basal cell skin cancer on her back and maternal grandmother with unknown skin cancer. And she reported a history of multiple blistering sunburn and extensive tanning bed use. And this was a clinical picture on her right shoulder. You can see extensive background sun damage on her shoulder and upper back area. So I looked at the lesion under dermatoscope. Here you can see brown structureless areas, atypical pigment networks, and grayed out granules. You can also see multiple colors here, including light brown, dark brown, pink, white, and gray areas. So I did a deep shave biopsy, and the result showed early melanoma in situ. So the question is, what are some of the risk factors that lead to cutaneous melanoma development? Risk factors for a melanoma can be divided into 3 categories: environmental factors, genetic factors, and phenotypic manifestations of gene with environment interactions. UV exposure is a major risk factor for melanoma. Clinical and epidemiologic evidence demonstrates higher risk of melanoma in people with extensive or repeated intense exposure to sunlight. UVB radiation has a wavelength of 290 to 320 nanometer and closely associated with development of melanoma. This was most striking when melanoma incidence and mortality rates in Europe versus Australia were compared, with both incidence and mortality being 5 to 10 times higher in Australia. UVB radiation is most intense at the equator, while UVA intensity varies less across latitudes. Melanoma incidence was increased in white population living closest to the equator. With regard to UVA radiation, it has a wavelength of 320 to 400 nanometer, and it plays a role in melanoma incidence in patients with extensive tanning bed use and PUVA therapy. PUVA stands for psoralen plus UVA therapy for psoriasis, and we also use it for other inflammatory. We used to use it more for other inflammatory conditions in the past. Major case control studies that were analyzed in a systematic review assessing sun exposure, sunburn, and melanoma incidence depicted that intermittent sun exposure and sunburn in adolescence or childhood were strongly associated with an increased risk of melanoma. The type of the melanoma that's associated with greatest cumulative sun exposure is lentigo maligna melanoma. And this is more common in older individuals in the head and neck region. All right, the other risk factor for melanoma development is immunosuppression. So de novo melanoma occurs with increased frequency. Immunosuppressed patients, including organ transplant patients, patients with lymphoma, and patients with HIV. Population studies on renal transplant patients showed 3 times greater likelihood for the development of melanoma in organ transplant recipients compared to the general population. The other major risk factor for melanoma development is genetic factors. So one of these factors is people who have a family history of familial atypical multiple melanoma and Mohs syndrome. This is an autosomal dominant disorder characterized by multiple melanocytic nevi, usually 50 to 100, and a family history of melanoma. And it's associated with mutation in the CDKN2A gene. And some patients with this syndrome can show an increased risk of development of pancreatic cancer and possibly other malignancies. And their lifetime cumulative incidence of melanoma could approach nearly 100%. And the atypical Mohs syndrome, also called dysplastic nevus syndrome, refers to patients who have 50 to 100 nevi, at least one of whom is which is above 8 millimeter in diameter, and at least one with atypical features, but without personal or family history of melanoma. And these patients are at risk of melanoma development. Germline variants of melanocortin-1 receptor genes have been found to correlate with a melanoma risk. And this MC1R, or this melanocortin-1 receptor gene mutations, people carrying this loss of function mutation in this gene usually have one of the following features, including red, auburn, or strawberry blonde hair on the scalp and beard, fair skin, light eye color, freckling, sun sensitivity, including poor tanning response, and having multiple solar lentigens. And these patients seem to have family members with similar characteristics as well. And so these patients are 2 to 4-fold increased risk of melanoma. And the other genetic factor is xeroderma pigmentosum. This is a rare autosomal recessive syndrome that results due to mutation in DNA repair. This syndrome is characterized by severe photosensitivity, skin pigmentary change, and malignant tumor development, including melanoma. So the strongest independence risk factor for the development of cutaneous melanoma are those that reflect combination of genetic susceptibility and environmental exposure. These include melanocytic nevi, atypical melanocytic nevi, FLHs, and solar lentigens. You can see here 5 epidemiologic studies and 1 meta-analysis that shows the relative risk of developing melanoma for a given number of melanocytic nevi. You can see here on the x-axis the number of common melanocytic nevi, and on the y-axis relative risk of developing melanoma. As you can see here, the more nevi you have, especially above 100, the risk is higher. The risk of developing melanoma is higher. Atypical nevi are benign acquired melanocytic neoplasms that share some of the clinical features of melanoma, such as asymmetry, irregular borders, multiple colors, and diameter above 5 millimeters. Up here, this is also epidemiological and meta-analytic study. On the x-axis, you can see the number of atypical nevi, and on the y-axis, the relative risk of developing melanoma. The more atypical nevi a person has, the more likely he will be at risk of developing melanoma. And usually around 5 atypical nevi, 5 and above, it increases the risk of melanoma development significantly. Aphellates and solar lentigens are risk factors for melanoma development. And a personal history of melanoma is associated with a higher risk of developing a second primary cutaneous melanoma. Although the risk is highest in the first year after the initial diagnosis, it persists over time. And the estimated risk of developing a second melanoma could range from 2 to 11% at 5 years. In summary, risk factors for development of cutaneous melanoma include genetic factors, including family history of cutaneous melanoma, lightly pigmented skin, tendency to burn, inability to tan, red hair color, DNA repair defects, and environmental factors include intense intermittent sun exposure, chronic sun exposure, living in equatorial latitudes, PUVA therapy, tanning bed use, especially under the age of 35, and acquired immunosuppression. And the combination of gene and environmental factors together include having increased acquired melanocytic nevi, atypical melanocytic nevi, and having multiple solar lentigens. And thank you for your attention.
Thank you, Etzep, for that review. I think it's a good introduction to the next talk. And I think there were some medical terms that people who are lay audience might not have understood. So if people have questions about terms, maybe we can address them in the panel discussion. For the next presentation, I think we're going to talk about some very interesting research, which has really been led by Ken Terziak. Dr. Terziak is a tenured professor in the Department of Oncology and Pediatrics at Georgetown University School of Medicine. He's also co-leader of the Cancer Prevention and Control Research Program at the Georgetown Lombardi Comprehensive Cancer Center. He's a member of something called the Fisher Center for Hereditary Cancer and Clinical Genomics Research, which is at Georgetown University, and a senior scholar in the Georgetown University Center for Child and Human Development, and is on the faculty of the Department of Psychology. His research, which you'll hear about from Marcelo Slayman in a second, focuses on developmental and biobehavior aspects of cancer research, communication and intervention, including public health genomics, tobacco control, and skin cancer prevention. And importantly, he is a principal investigator on a new 5-year grant from the National Cancer Institute entitled a cluster randomized trial of sun safety prevention for young children and their families living in rural and underserved communities. And there'll be a presentation talking about addiction to indoor tanning, and that presentation is going to be given by Marcelo Slayman, who is a program manager in the Cancer Prevention and Control Program at Georgetown. Lombardi. He's came in 2022 after he graduated from the University of Virginia with a degree in biostatistics. And as part of our mission at Georgetown is also education and training. And Marcelo has been training with Dr. Terziak, doing research in behavioral and preventative medicine, including primary prevention of skin cancer. He also manages a lot of other projects within the program and hopes to go to medical school soon. So Marcelo, why don't you go ahead and present what you've been working on with Dr. Terziak.
Great. Thank you so much for the introduction. Let me share my screen. Great. So good morning and welcome again to everyone. Thank you very much for the opportunity to address this group. Again, my name is Marcelo Slayman Jr., and I'm from the Cancer Prevention and Control Program at Georgetown Lombardi. Along with my colleague, Dr. Ken Terziak, we're going to present some information about a topic that's gaining increased attention in the melanoma advocacy community, which is indoor tanning, the health harms it poses, and the risk for addiction. Throughout my presentation, I'll refer to what an addictive behavior is, how to recognize it, why people who repeatedly indoor tan fit this description, and the implications for how to help them. Let's start off by talking about what an addiction is. In the fields of psychology and psychiatry, addiction involves behavioral patterns of symptoms caused by using a substance that an individual continues engaging in despite its negative effects. The criteria fall into four basic categories: impaired control, physical dependence, social problems, and risky use. Like other problem behaviors, misuse generally worsens over time and can help to determine how severe an addiction has become. This helps specialists figure out the best course of action for someone struggling to regain control. For background, the most common addictions in the US are alcohol, opioids, cannabis, nicotine, and amphetamines. Most affect the brain's reward circuit by flooding it with the chemical messenger dopamine. Surges of dopamine in the brain's reward circuit cause the reinforcement of pleasurable but unhealthy activities, leading people to repeat the addictive behavior again and again in order to feel good or avoid feeling bad. Part of our research is designed to ask and answer the question of what is the phenomenology of addiction to indoor tanning, as well as why some individuals become addicted to indoor tanning, whereas others do not. You might be wondering, how could indoor tanning be considered an addiction? Well, take a quick look at these sentences. This passage comes from a report on cigarette smoking. It's one of the most common and, at one time in our cultural history, socially accepted addictions. It's also among the most difficult addictions to change and harmful. I'll give you a moment to read it. Notice how I've omitted the word smoking. If you fill in the blanks with the words indoor tanning, these sentences actually read just as true. In this presentation, I'll cover some of the reasons why and what we at Georgetown Lombardi are doing to help raise awareness and fight this problem in the interest of skin cancer prevention. Now let's turn to indoor tanning. On the right, you'll see a picture of a typical tanning bed. Most users encounter these in places you would expect, salons, gyms, but also health spas, ironically. Most users are encouraged to start slowly and gradually increase their exposure to its ultraviolet radiation light over time. For example, a 5-minute session that steps up to 12 minutes or longer. Because tanning lamps differ in UV strength and output, there's no single formula for comparing indoor and outdoor tanning exposure times. Users are also encouraged to wait at least 48 hours between sessions and avoid daily use. However, they're also cautioned if they wait too long between indoor sessions, their tan may start to fade. 3 sessions a week are typical, and then twice a week for maintenance. Interestingly, the FDA indicates having no more than 1 tanning session a day to avoid overexposure, and it also recommends stopping when the skin starts to sting. Although by that point, the damage has already begun. And much like tobacco products, the FDA recommends that sunbeds also carry warning labels, similar to the examples shown here, that curtail their use by minors and link its use to skin cancer. But what does the general public encounter when it comes to indoor tanning? Here I'm sharing some popular media coverage. For example, the sensational headline on the left from a New York Post about a mom who used an indoor tanning bed so much that she claimed to have been addicted to it, and even though her doctor had identified cancerous damage to her skin. In another example, celebrity Kim Kardashian was called out for extolling indoor tanning's virtues for maintaining her good looks and giving her a healthy glow from the sunbed she keeps in her private office, while at the same time, her sister Khloe was undergoing treatment for skin cancer. These and other social media posts contribute to the public's misunderstanding about the true nature of indoor tanning and why it can be even more damaging to your skin compared to natural sunlight. Social science research, such as the example shown at the top, on this topic confirms widespread misinformation about the health-harming effects of using a tanning bed. Public health researchers, clinical practitioners, and the melanoma advocacy community are all increasingly being called upon to help educate people about indoor tanning's dangers. And again, like cigarettes, to advance the harm message that when someone uses this legal product as intended, it can cause cancer, especially in young people. So how common is indoor tanning and what's being done to regulate the industry? Well, about 10% of adults and slightly fewer children report engaging in this behavior. That's nearly 8 million people in the US alone. Some states are trying to catch up to this problem by enacting laws that regulate the industry, including restricting minors' access to sunbeds without a parent's permission. And despite what's known about the harms of UV exposure to the skin, most surveyed adults report using tanning beds at least every other week. But anecdotally, we suspect the frequency of their use is actually greater, and let me share with you some additional data about high-risk populations. According to the most recent US Surgeon General's report on this topic, which is 10 years out of date now, the risk of melanoma from indoor tanning exposure is highly significant. For example, compared to people who never or infrequently tan, those who have an indoor tanning bed, who have used an indoor tanning bed before their 36th birthday, those who indoor tan more frequently, and those who have done this more than 10 times in their life have an excess risk between 34 and 59%, which refers to the over and above rate of occurrence of melanoma that's associated with UV exposure. No matter how you look at it, your risk of melanoma increases substantially the earlier in life you engage in this behavior and do so with greater frequency and at greater intensity. The most recent clinical epidemiologic data indicate a 6-fold increased risk of melanoma before age 30 that is directly due to indoor tanning. Throughout my presentation, I'll refer to Georgetown Lombardi's ultraviolet study that Dr. Teresiak co-led. More to come on that in a moment, but for now, let's look at some differences in tanning behavior. In a sample of nearly 400 college-age young women we spoke with who indoor tan, 41% reported doing so for an event, such as a party. Another 41% reported doing it seasonally, such as during the winter and spring months when it's generally too cold to tan outdoors in our area. And another 18% reported regular use, which is well above the national average. And why do people do this? What drives their behavior? These data are based on both experimental research as well as clinical observation. First, let's start with what we call appearance motivations or aesthetics. Many people, and especially college-age young women like in our ultraviolet study, believe that they look and feel better about themselves with a tan. Second, let's consider social media's sway and influence. Here in the center of our slide, I'm showing you an actual social media toolkit that any sunbed business owner could use for free to help advertise their products. And on the right, I'm showing you an example of one of these types of ads that could easily come across your AI-driven social media feed on Facebook, Instagram, or YouTube. These posts will portray the perceived upsides of indoor tanning and play into people's, and especially young women's, appearance-based motivations, and do so without any attention paid to the downside risks and health harms. Congress, the FDA, and other federal regulatory agencies are too quiet about this issue. Case in point, the 9th and 10th bullets on the ad clearly say, and I quote, "Indoor tanning reduces the risk of sunburn, but use sunscreen outdoors." This is both misleading and inaccurate and goes largely unchecked by the average consumer. Now, the 4th bullet on my slide is really important, and it is at the heart of our research, and it has to do with the biobehavioral rewarding properties of indoor tanning for some individuals. Let me explain further so you can better understand how we got here. First, let's review what happens beneath the skin and with a detour to the brain. In preclinical studies, skin exposed to UV light increases beta endorphin levels in the blood. These circulating hormones can block pain sensations. When skin is repeatedly exposed and then stopped or blocked, what we see are classic signs of psychological withdrawal, including irritability and eating and sleeping disturbances, and attempts to avoid the withdrawal by finding ways to regain access to the UV light source. The depth of UV radiation penetration is relative to its wavelength, as discussed before. UVB radiation is a shorter wavelength penetrating the upper layers of the epidermis and is responsible for acute skin damage, such as a sunburn, but also yielding chronic skin damage and carcinogenesis with repeated exposure. UVA radiation is a longer wavelength, penetrates through the epidermis to the dermis, and is implicated in photocarcinogenesis. To put sunbeds into context, levels of UVB radiation are typically twice that of natural sunlight, and levels of UVA, the most harmful type, are upwards of 4 times that of natural sunlight, and with substantial variability across sunbed products. This, in turn, becomes one's biological basis for the addiction. But biology is only part of the answer. We also need to inspect people's behavior and do so in the context of their social circumstances to understand the addiction. So how do people respond to tanning bed exposures? Here we turn to our ultraviolet study again of college-age women who frequently indoor tan. We screened them using some of the psychiatric criteria I mentioned earlier. We asked them about how they felt and behaved when prevented from using a sunbed as they normally would, like preventing a smoker from smoking. We found that over 40% of these women reported that their tolerance for indoor tanning, meaning that they would remain in the sunbed for longer periods of time, could increase with more and prolonged use. The same was also true for their subjectively experienced physiological and psychological withdrawal symptoms, meaning they felt worse when they couldn't indoor tan. These same individuals tended to report knowing that they should not indoor tan as much as they do, but nearly twice as many, over 80%, would do so despite recognizing its skin cancer and melanoma risks. At the level of screening, nearly half of these young women met psychiatric criteria for an addiction. And even when followed up with more stringent clinical criteria, at least a fourth would be considered addicted to indoor tanning. And just to put a finer point on the 50% of those who exhibit an addiction-like response to indoor tanning and further build the evidence for the basis of indoor tanning as an addiction, here's a table comparing young women's cognitive risk profiles on the left to those who are not addicted on the right. You can see that across all of the dimensions we measured in the ultraviolet study, including feeling better while doing it, to thinking the benefits outweigh the risks, and even belonging to a friend group that uses together, all of those behaviors fit a profile of someone experiencing an addiction. As much as we now understand about the why of this behavior, we also need to recognize how it starts and is perpetuated by our social environment. Remember, to engage in an addictive behavior like indoor tanning, there must be a motivation and an opportunity to do so, meaning there must be a tanning bed accessible to you and is in some ways desirable. So let's suppose your friends mention they're going tanning and invite you to join. This is the motive. For those in DC, if you open your phone and pull up Google Maps right now and search for indoor tanning salons, you'll see something just like this. Within a few miles of where we sit, there's 3 colleges shown in the red boxes and 7 indoor tanning salons shown as red circles. Notice how close and convenient these salons are for their target audiences. This is the opportunity. And if you step inside one of those salons, you might see an ad just like this one that recommends you tan up to 3 times a week and that you get to know your skin type. Notice that for black skin, the sign says you'll never burn. This is a highly misleading and very dangerous message to convey from a clinical and public health standpoint. I'd now like to share with you some new and exciting science that was begun right here at Georgetown Lombardi, and it's from a randomized controlled trial of a digital health intervention for helping young women stop indoor tanning. As part of this trial, women enrolled in the study received 2 text messages a week for 4 weeks about the risks of indoor tanning, along with messaging to increase their motivation to stop. Importantly, these messages were personally tailored using an algorithm based on their readiness to change their indoor tanning behavior, from not at all to taking the first steps towards stopping to staying away from sunbeds entirely. And what did we find? Well, now there are even more parallels to smoking because the outcomes were modest but favorable. In most studies of helping smokers quit using tobacco, you can generally expect a success rate of about 10 to 15%. This trial performed somewhat better at 19% among those who received the text messages. That means nearly 1 in every 5 young women who received the intervention were able to stop using a tanning bed. This is double that of women randomized to the control condition. Importantly, you'll also see that after a month we finished our intervention, there was very little change in women's motivation to quit indoor tanning in the control group. But for those in the intervention program, their motivations to quit went up significantly. And increasing someone's motivation to behave in a different and healthier way is fundamental to attaining lasting change. Where we saw even more success was about 3 months later, after the messaging had a chance to take hold in people's minds and behavior. By then, the quit rate for indoor tanning was up to 24%, with even stronger motivation to quit, which again should translate into staying away from tanning over time. But while encouraging, these results still suggest that there are more people than not who didn't find success in the program. We will need better and different strategies to help them change. As we know, changing something about ourselves can be difficult, and changing something we find enjoyable is even harder. Having an addiction amps up this challenge, which leads me to my final slides and to say something about prevention. It's Benjamin Franklin who's famously credited with saying, "An ounce of prevention is worth a pound of cure." So Dr. Tersiak and I have expanded our focus to helping people, and younger children in particular, stay away from harmful UV exposure and not become addicted to any form of intentional tanning. We're teaching them healthier ways to stay safe in the sun as part of a multi-state cluster randomized controlled trial supported by the National Cancer Institute of a sun safety intervention for youth. We're intercepting families at the point in time they enroll their children into recreational spring sports leagues like T-ball, and we're teaching their coaches and parents about ways to keep very young players safe from the sun. This is the RAISE study, our Rural Adult and Youth Sports Study. Over the next 5 years, we'll be looking at how to best implement RAISE messages and strategies at the community level, and especially among disadvantaged populations who experience high melanoma burden. On the right, I'm showing you some of the preliminary results. Children in our RAISE intervention were significantly more likely to behave in sun-safe ways while playing sports, including wearing a wide-brimmed hat, avoiding being in the sun during peak UV hours, and their coaches were significantly more likely to provide them with sunscreen, have them wear sunglasses, and to help educate the community by posting banner ads at ball fields about the need to protect yourself from the sun, and especially while playing sports. We hope to report back to you on our progress. I'll also mention how we're working with a local makerspace in the DC area to empower young children from under-resourced communities to learn about cancer biology and prevention, including skin cancer. We do this by challenging them to think and invent like a scientist and build and test better shade structures to help protect against skin cancer while outdoors. As of today, more than 500 children from Title I schools in DC and Maryland have participated in our Young Scholars program, and thousands more have joined our online Sun Protection Maker Playground. By strengthening children's understanding of what causes skin cancer through hands-on learning exercises, we believe that this will help them stay safe while enjoying the outdoors. I'd like to thank all of our colleagues who have been instrumental in this research, especially Dr. Darren Mays, who is now with The Ohio State University, Dr. Yelena Wu at the University of Utah, and Dr. Mike Atkins from Georgetown. Our final take-home message is this: proper skin cancer prevention should start early in life and with strong messaging about UV safety. Teaching children and adults about behaviors that increase and decrease their melanoma risks remains important, along with helping people change their behavior to lower the odds of skin cancer happening. I appreciate your time, and Dr. Tersiak and I look forward to the discussion.
Thank you, Marcella. That was a wonderful presentation, really exciting research that I think has an opportunity to have a major impact on something that's a major cause of melanoma and other skin cancers in America. I think it's a good speech that hopefully will ensure your admission to medical school. So we're going to move on to the next speaker, and it's going to be a discussion or a presentation by Dr. Jonathan Girantano, who is a fellowship-trained head and neck oncologic and microvascular reconstructive surgeon. So that means he operates on the head and neck, and he also operates on small vessels and reconstructs them in the head and neck. And he's an assistant professor in our department of otolaryngology, which is ear, nose, and throat, and head and neck surgery at MedStar Georgetown University. And he does his practice involves the treatment of both malignant and benign diseases affecting the head and neck, as well as complex reconstruction of head and neck defects using microvascular surgical techniques. And melanoma in the head and neck is a really complex problem. It's really a multidisciplinary problem that involves input from not only surgeons and dermatologists, but also plastic surgery, frequently radiation oncology, and medical oncology. And so it's one of the major reasons why we have a multidisciplinary cutaneous oncology skin cancer program that meets every week to discuss all of our new patients and how they should be managed before we actually start their treatment. And Dr. Girantano is an important part of that program. And he's going to talk about some of the things that are in the evolving role of head and neck surgery in the management of melanoma. So take it away.
Great. Thank you, Dr. Atkins, for having me. Hopefully everybody can hear me. I'm going to go ahead and share my screen. All right. Well, good morning, everybody. And thanks for spending your Saturday morning learning about melanomas. I'm Jonathan Girantano, as Dr. Atkins mentioned. I'm a head and neck reconstructive surgeon at MedStar Georgetown University Hospital. And the role of head and neck surgery in melanoma, as Dr. Atkins alluded to, has really changed quite a bit. And it's seen some really rapid changes in only the last 5 to 10 years. So we've really had to keep on our toes and really keep, up with the progress that has been made in the scientific community with the treatment of cutaneous melanomas. And I'll be speaking on how our role has evolved over the last few years as related to cutaneous melanomas. Just for disclosures, I do receive some material research support from the AMBU Inc. That has no relation to this talk at all today. The three primary objectives I would like to discuss this morning are how the role of the head and neck surgeon has changed in the care of advanced cutaneous melanomas. To look specifically at some of the more common operations that we as head and neck surgeons do and what the indications and the role those surgeries play in the care of the melanoma patient, specifically sentinel lymph node biopsy, parotidectomy, and neck dissection. And then actually just to look at kind of the evolving function of surgery for cutaneous melanoma in this new era of immunotherapy that we have found ourselves in. Some very quick statistics. The incidence of melanoma is rising worldwide. The American Cancer Society estimates that in the United States this year in 2024, we'll have over 100,000 new cases of melanoma and over 8,000 melanoma-related deaths. Thankfully, in terms of staging, most melanomas are caught fairly early. Most of them are stage 1. 3/4 of melanomas are caught at stage 1. But these, stage 2 and above melanomas do put patients at higher risk for melanoma-related death. And as we only see the incidence rising, it's really imperative that the public is aware of the risks of melanoma, and it's imperative that we as physicians are optimizing the treatment for these patients. With regard to the head and neck region, about 25% of all melanomas throughout the body will occur in the head and neck region. The face tends to be kind of the far and away place where we predominantly see melanomas, followed by the scalp and or the neck, and then lastly the lip, the ears, or the eyelids, which are less likely. The amount of cumulative solar damage helps to play a role in exactly what type of melanomas will show up in the head and neck. The face, specifically the scalp, the back of the neck, those are areas that are exposed to the sun pretty much at all times. And depending on what your geographic location is, what your profession is, we see a lot of farmers, a lot of people who live in very warm, sunny areas, Arizona, California, Florida, who have this very chronic sun exposure who will come in with melanomas. Though also this kind of acute intermittent sun exposure. So you go to the beach, have lack of sunscreen, you get a really bad sunburn, and you do that a few times, and that can put you at increased risk for certain variants of melanoma. And there's all these different rare variants that we also see in the head and neck region. So what's special about the head and neck? That's what a lot of people ask. For one, cutaneous melanomas in the head and neck tend to have a worse prognosis compared to cutaneous melanomas in other sites of the body. There have been studies looking at the actual location of melanoma and how that affects survival. And head and neck melanomas have been found to have a worse 5-year disease-free survival and overall survival compared to melanomas on the extremity and on the trunk. And patients who are diagnosed with a melanoma on their face or their scalp or their neck are almost twice as likely to die of the disease compared to a melanoma in other sites. We don't have a great explanation as to why that's the case. One big factor about the head and neck region is that, especially when melanomas are occurring on the face is an inherently cosmetic area. Your face has a lot of importance in terms of your public perception. It has a lot of psychosocial impact and importance to individual patients. So oftentimes we suspect maybe that these melanomas are just not being treated aggressively enough, the surgery's not aggressive enough, and that puts patients at risk for local recurrences or disease spread, because certain practitioners might be afraid to really treat these as aggressively as they need to be treated for fear that it could result in cosmetic deformities. And that really kind of has been the historical role of the head and neck surgeon. If you asked, 20 years ago, if you came to a head and neck surgeon and said, what do you do about melanoma? They would have said, take it out, big margins, 2-centimeter margins, and take out the lymph nodes. For most of the 20th century, removal of the lymph nodes would have been a radical neck dissection. The patient in the bottom of the screen where you can see the scars on the neck, that's an example of what a patient would have looked like after a radical neck dissection, which was it was a useful operation and had good oncologic outcomes, but at the expense of really severe functional limitations after that surgery. In that surgery, one of the big muscles in the neck, the sternocleidomastoid muscle, was removed. The jugular vein was removed, the nerve to the trapezius was removed, and oftentimes patients had both a cosmetic and a functional deformity in their neck and in their shoulder following that surgery. Parotidectomy is another surgery that would have been commonly mentioned, and that is because the parotidectomy, or the parotid gland itself, which is a saliva gland on the side of the face, has lymph nodes inside of the salivary tissue that can drain the melanoma if it is on the ear or the face or the scalp. And so this is where my mouse is pointing on the right side of the screen is an example of a patient who's had a parotidectomy with no reconstruction. You can see there's a pretty big scar on the neck. There's a big sunken deformity of the face where the parotid gland is missing. And that patient is just very obviously has had surgery and has a deformity present. In the more modern times, sentinel lymph node biopsy has become a much bigger player, and we'll talk about that a little bit a few slides from now. But that's a newer technology where instead of trying to take out all the lymph nodes in a specific region of the neck, we're really just focusing on the primary lymph node that is draining the first lymph node that drains where the actual melanoma is. And we have a few ways to try to isolate and locate that sentinel, that first draining lymph node. One of which is by having our colleagues in nuclear medicine perform something called a nuclear scintigraphy, where they inject a radio tracer into the actual skin melanoma site And then we do a special nuclear medicine CAT scan to identify which lymph node looks like it has the radio tracer uptaking it. And we actually have a special device called the True Node, which is a gamma probe that we can use in the surgery to help identify which lymph node has the radio tracer that's accumulated inside of it. And doing that, as well as injecting a blue dye around the melanoma called isosulfan blue, gives us about a 96% identification rate of the sentinel node. And that's become a much more common thing in the modern era that we are doing for melanoma patients. As a surgeon, I have to admit that whenever it comes to cutaneous melanoma, there is a problem with surgery. And that's, up until the immunotherapy era, this was one of the big paradoxes of melanoma treatment, is that as opposed to the other types of, both skin cancer and cancers that we see in the aerodigestive tract and the head and neck region, which will show up in lymph nodes. And very commonly, if it shows up in a lymph node, it's a pretty large, obvious, palpable or visible lymph node on imaging. Melanoma tends to spread via what we call micrometastatic disease. So it'll have much smaller amounts of the actual cancer of the melanoma in lymph nodes. And very commonly, you can't feel that in the neck. The patient won't feel it or see it. And if you were to image and even get a PET scan or some of the most high technology scans we have, it still might not show up. And because of that, whenever we were using surgery alone to treat melanomas, for the more intermediate and deeper stage melanomas, for stage 2B and C, the risk of relapse was upwards of 35% with surgery alone. And with stage 3 melanomas, the risk of relapse and having distant metastatic disease approached 90% with surgery alone. So while surgery is very good for achieving local and regional control of melanomas, for the more advanced stages, even if you put someone through a very big surgery, people could still relapse and have disease elsewhere later on that they could die from. So in the last 10 years, we've had 2 really big landmark studies that have come out that have pretty radically oriented the role of the head and neck surgeon in melanoma treatment. And the colloquial term for these studies was the MSLT1 and the MSLT2. So the MSLT1 came out first, and these are big, nationwide, randomized controlled trials, which gives us the absolute best evidence that we need to not use retrospective data, not look back on patients we've already treated and try to gain information and insight, but actually to look prospectively, to randomize, to try to take out all chance of confounding or factors that might cloud the data and really get the best sense of what is the best way to treat these patients. So the MSLT1 started enrolling in the 1990s and was finished by the early 2000s. And in that study, they were randomizing intermediate and deeper grade melanomas to either surgery alone or surgery with a sentinel lymph node biopsy. And this study itself really confirmed that sentinel lymph node biopsy has a valuable role in determining the prognosis of melanoma. If a sentinel lymph node was positive, patients who went on to have early nodal dissection in the intermediate thickness population tended to have better survival and certainly had better regional and local control of disease. And so that study really put sentinel lymph node biopsy on the map as a useful thing in the treatment of melanoma. And the MSLT2, which had its data published in 2016, 2017, went a step further, where if you did have a positive sentinel lymph node biopsy, they randomized those patients to either going on to have the remainder of the lymph nodes removed in that area, or just to observe the area with ultrasound, and if a lymph node popped up, to go back and then take the lymph nodes out. And actually found that the melanoma specific survival, so what the survival was related to the actual melanoma itself, was similar whether you immediately operated and took the lymph nodes out or whether you just watched. And that had a massive impact, where this was a good study just looking at surgical trends from 2016, which was before the MSLT2 was published and really before more of the common immunotherapy drugs took hold, to 2018. So only 2 years. And what that that chart is signifying is that the rate of surgeons performing immediate completion lymph node dissection, so immediately taking the lymph nodes out after a positive sentinel lymph node biopsy, dramatically decreased. And so that has been kind of the really big shift that we've seen, where we're not immediately jumping to taking out lymph nodes. As Dr. Atkins said, this is done in a much more multidisciplinary fashion. And once we do have a sentinel lymph node that's positive, we'll talk about what we do nowadays. The head and neck can be a challenging area for sentinel lymph node biopsy and lymph node dissections. Whereas the inside of the mouth, the mucosal surfaces of the head and neck have very predictable drainage pathways that we know based on anatomical studies and on 3 decades, 4 decades of research and literature. The skin can kind of drain wherever it wants to. It's much less predictable. And so that sets us up as surgeons to oftentimes be more extensive in the actual areas of the neck that need to be dissected and the lymph nodes removed in order to feel that we're fully treating the area. And oftentimes make surgery for melanomas larger than they might be for cancers happening inside the mouth or in the back of the throat. This is just an example of what the anatomy looks like after a neck dissection has been performed. This one patients had a parotidectomy as well. So there's lots of cranial nerves, lots of vital neurovascular components in the head and neck that make this very tedious, very important surgery to make sure that patients do not have nerve deficits that result in altered speech or swallowing function or shoulder function after these surgeries. This is some more data recently that has been published just trying to pinpoint where these lymph nodes are more likely to drain. Though at this point, most surgeons will still perform a comprehensive neck dissection for melanomas, regardless of what the exact subsite is. The surgical removal of the lymph nodes and the melanoma itself is one part of what we do, but then reconstruction is the entirely separate second part of what we do. And I'm just going to I would spend an entire hour talking about reconstruction for these melanomas, but we do have a lot of tools in our tool belt now, and that's one of the biggest things to know. And whereas previously in the older days, cosmetics, they were valued, but they really were not imperative to many head and neck surgeons doing head and neck surgery for cutaneous skin cancers. Really nowadays, for every single patient that we're doing surgery on, we're trying to maximize the cosmetic appearance of the face and the head and the neck as much as possible. It's not always possible to have an ideal cosmetic outcome, but that's always at the top of our minds as we're doing these surgeries. Thanks to the work of Dr. Shan Baker, who is a facial plastic surgeon at the University of Michigan, we have a very good understanding of these cosmetic subunits of the face. And so anytime there's a skin cancer on the face, we divide it up into a subunit, and then we try to make the decision what's the best way to reconstruct that subunit. For me, I'm a microvascular reconstructive surgeon. So Dr. Riley, my facial plastics colleague, is commonly coming in to do the smaller reconstructions. And whenever there's a bigger reconstruction, like this patient who had this obvious recurrent skin cancer below the ear and kind of right at the bottom of the earlobe, in this case, we were able to do a parotidectomy and a neck dissection and then just use his normal skin to kind of pull excess skin up in what's called a cervicofacial advancement flap. That's a very nice option in patients who are a bit older, who have more laxity and more give to their skin, that we can just kind of pull the skin around itself. Unfortunately, in the head and neck region, we very often don't have that option. So commonly, we're trying to remove tissue from one area to the other. This is an example of something we call a regional reconstruction, which is a flap based on the supraclavicular artery. So that artery, we can actually design a flap of tissue over the shoulder, and we can transpose it upwards and reconstruct defects, in the front part of the ear or over the parotid region. This is a very unfortunate patient who had a multiply recurrent melanoma. So all of this kind of tissue you see is melanoma, and that's after she's already had surgery as well as immunotherapy. And so she required a very large scalp resection to get negative margins with exposed bone underneath. In her case, we used a free flap. We used muscle from her side, the latissimus dorsi muscle. And we actually transferred that entire muscle up onto the scalp and connected the blood vessels in front of the ear. And this is her about 2 weeks after surgery, where the skin graft is healing over the muscle, reconstructing that area. This is another scalp cancer with another very large, big resection. And this gentleman, he had very thin thighs, and I used an anterolateral thigh flap, which is another free tissue flap taken from the lateral part of the thigh, where we suture the blood vessels in front of the ear. Worked very well in terms of covering his scalp, though you can see the skin from the thigh is dramatically lighter in color match compared to the scalp skin. And that's from a lifetime of the scalp skin being exposed to the sun, whereas his inner thighs had really never had much sun at all. So that's the one downfall of that reconstructive option. We have a very strong multidisciplinary melanoma team at MedStar Georgetown University Hospital. And this encompasses so many different specialties because for a melanoma patient, specifically in the head and neck, to really get the optimal treatment, you need each one of these people's advice and guidance to help really make sure that the optimal treatment outcome is achieved. Dr. Riley is our facial plastic surgeon, so he's a head and neck surgeon like myself, who really focuses more on cosmetic surgery, but does these larger reconstructions with me. Dr. Deng, one of our dermatologists and Mohs surgeons, does quite a bit with our melanoma patients, and she'll be speaking today. Dr. Esposito is our nuclear medicine radiologist, so all of the sentinel lymph node biopsies Dr. Esposito is helping with and reading. Dr. J and Dr. Thacker are neuroradiologists, so whenever we're getting scans of these more complex melanomas, they're the ones really helping us to identify where lymph nodes might be, or where these melanomas are spreading. Dr. Atkins, Dr. Gibney, our medical oncologists, Dr. Cardis, our dermatopathologist, who reads all of our melanoma specimens. They all go to Dr. Cardis to be read, and Dr. Ahn, who's our head and neck radiation oncologist. And we actually have more members of the team, but without that many members, we really can't make sure that melanoma patients are getting the best treatment. So I play a role in that, but everybody serves a really integral, vital role in the care of these melanoma patients. At Georgetown, for aggressive stage 1 melanomas based on pathology, and basically all stage 2 and above melanomas will get a wide local excision and a sentinel lymph node biopsy. For those sentinel lymph node positive patients, they all have multidisciplinary discussion at our tumor conference and will go on to receive adjuvant immunotherapy with our medical oncologists. If there's evidence of clinical progression of disease, then we start discussing neck dissection and parotidectomy if that's indicated, to help ensure that we have regional control of disease. If there's palpable or clinically apparent disease, which is less common, those patients still go on to have immunotherapy up front, and then oftentimes we'll go back and remove the lymph nodes from the neck and do a parotidectomy. And that gives us a few different advantages, because we can actually see the clinical response to the immunotherapy while also trying to maximize regional control. So my job as a head and neck surgeon has really dramatically changed in the last 25 years, and it's actually changed in just the last 5 years. It's a very different, and I'm sure in the next 5 to 10 years, it's going to change even more. Melanoma treatment really needs to be conducted in a multidisciplinary fashion. If you take anything away from this lecture, that's the one thing I would say. Everybody's important, and it has to be done in a multidisciplinary fashion, especially in the head and neck region. Currently, wide local excision, sentinel lymph node biopsy are the most common operations we're doing, though lymph node removal like neck dissection and parotidectomy is still important for clinically apparent disease. And those are my references, and thank you so much for listening this morning.
Thank you, Jonathan. That was a great presentation, and I think a good lead-in to our next presenter, who is Dr. Min Deng, who's Associate Professor in the Department of Dermatology at MedStar Washington Hospital Center and also MedStar Georgetown University Hospital. And she serves as Director of the Mohs Micrographic Surgery and Residency Program Director. And her clinical interests include cutaneous oncology, Mohs micrographic surgery, surgical training, and graduate medical education. She's an active fellow of the American College of Mohs Surgery and a member of the American Society of Dermatologic Surgery and Association of Professors of Dermatology and the American Academy of Dermatology. And so just as an introduction to the topic, Mohs surgery was something that we use commonly for non-melanoma skin cancers, but we are finding as we do our multidisciplinary evaluation of each patient that there are some patients where Mohs surgery would be appropriate for our melanoma patients. And Dr. Deng is going to tell you about that.
Thank you so much for that introduction, Dr. Atkins. Let me share my screen. I've got a couple of them, so let me figure out which screen it's going to show up on. Okay, can everyone see my PowerPoint?
Looks good.
Okay, perfect. Thank you so much. So thank you again so much for that generous introduction. And I thought, Dr. Georgetown, your talk was excellent. So I'm really going to be discussing the role of Mohs surgery in the management of melanoma. As Dr. Georgetown already mentioned, it is absolutely a multidisciplinary specialty. You know, the way we approach melanomas is not a one-size-fits-all. And in the last 5 to 10 years or so, there has been more literature supporting the use of Mohs surgeries. Okay. So as everyone knows, you know, our primary goal with melanoma is to educate, prevent, but in the case that someone does develop a melanoma, early detection is going to be key, and complete surgical removal to, you know, optimize patient outcomes is really the goal. We have excellent treatments for advanced melanomas, but we really would like to minimize, you know, the progression of melanomas into advanced melanomas. And so traditionally, the surgical management for melanoma has been wide local excision, or kind of conventional surgery. The reason we do wide local excision, I know Dr. Georgetown had mentioned 2-centimeter margins at one point, is because melanoma, in contrast to some of the other skin cancers, basal cell, squamous cells, is notorious for having subclinical tumor spread. So even though you may see a pigmented lesion on your skin and you know, be diagnosed with melanoma, we know that the cancer cells actually extend beyond what you can see with your naked eye. And so to account for the subclinical spread, many trials over the years have looked at, you know, what peripheral surgical margins would you need in order to get, you know, 95, 98% cure rates. And so over the years, we have predetermined standard peripheral surgical margins. Now, melanoma, just like any other cancer, doesn't behave, you know, symmetrically. It doesn't grow, you know, in a spherical ball. It can have asymmetrical growth. And so the key is that, you know, some of these margins, you may require 2 centimeters to remove all of the melanoma, but then inevitably you tend to remove some areas of normal skin as well. On the other hand, if you don't remove, you know, kind of the 1 to 2 centimeter margins, if you don't remove those wide margins, then you run the risk of leaving tumor behind, which is also suboptimal. The second point about wide local excision is that typically these specimens, these tissue specimens, are sent to the lab. And in the lab, they're processed vertically. So the piece of tissue that's taken, let's say it's a 1 centimeter lesion that's removed and sent to the lab. Typically, it's bread loafed or vertically sectioned, and the sections are extremely thin to be able to look at them under the microscope. So it's 4 microns. What that means is that for complete margin evaluation with the bread loafing method, you would need 2,500 sequential cuts through that tissue to be able to see the entire surgical margin. That's virtually impossible. And so for that reason, we don't trust, quote unquote, histologic margins on biopsies. We have to take sort of these extended margins. Now, that is great when you're on less complicated anatomical sites like the back, the arm, the thigh. but it may not be feasible in all anatomic locations. As Dr. Ajebo and Dr. Georgetown already mentioned, a lot of melanomas occur on the head and neck. That's where we get a lot of sun exposure. And so 1 centimeter or 2 centimeters on the head and neck is substantial. Additionally, one thing that many patients may not know is that there are no randomized controlled trials to inform the peripheral surgical margins or the depth of excision for melanoma in situ. So unlike the more invasive melanomas where there are a lot of studies, for melanoma in situ, we actually don't have randomized controlled studies informing those margins. So these are the NCCN guidelines. These are the guidelines that we use when we talk about surgical excision. I am primarily going to focus on the early stage melanoma. So melanoma in situ. So that's technically stage 0, means it has not invaded the skin yet. And then the thin melanoma. So ones that are 1 millimeter or less. So stage 1. So these are just some real patient cases that have come into me, just to kind of highlight some of the challenges with traditional wide local excision. So this was a gentleman who came in with a really subtle brown patch on the left nasal tip. And really, you had to take a Woods lamp to it. A Woods lamp is a UVA light that helps accentuate pigments. And so with that light, I could really better appreciate the margins of this really, really subtle brown patch. And this was a melanoma. And you can appreciate it's right on the alar rim. So, you know, with the NCCN guidelines for melanoma, currently they're anywhere between 0.5 centimeters to 1 centimeter. The question would be, you know, how much would you take? Would you take 0.5 centimeter? Would you take 1 centimeter? Do you go inside and remove the nasal mucosa? How deep do you take this? You know, a melanoma in situ on the back, you can take much more skin than you can here on the nose, where you just don't have much skin before you're down to cartilage. So again, we don't have a lot of prospective, you know, randomized trials to guide us in these decisions. And the risk is if you don't take enough, then you've left melanoma behind, and that can go on and cause further downstream problems. And this is the second case that, again, is a patient of mine. And this was a gentleman with an early invasive melanoma, 0.3 millimeters, right on the helix of the right ear. So again, if we were to go off of NCCN guidelines, the standard margins would be 1 centimeter. You know, so would you take 1 centimeter? That would essentially be his entire or vast majority of his ear. And then again, the depth, how deep would you take this? Would you take this down to cartilage? Would you take the periochondrium around the cartilage? Would you actually take the cartilage? And so again, with the standard margins, you know, those are very good guidelines for the vast majority of cancers, but they don't necessarily fit all cancers. So that's where the Mohs surgery technique comes in. Mohs surgery is fairly well established and considered the gold standard now for you know, non-melanoma skin cancers, especially on the head and neck, for the early localized skin cancers on head and neck. The difference between Mohs surgery and traditional surgery is twofold. Number one, it is the surgeon is processing the tissue in real time as we you know, perform the surgery. So we remove a piece of tissue, we take it to the lab, we process it right then and there via frozen sections. And so the surgeon is actually the one reading the tissue, and we're able to see, you know, if there's cancer, you know, is it at 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock, you know, is it deeper in the middle? And we go back and are able to more precisely geolocate any residual cancerous cells. So that's the first part. But the second part, and probably the more crucial part for Mohs surgery, especially when it comes to melanoma, is how we process that tissue. So in the same bread loafing analogy, instead of vertically sectioning the tissue, which has the potential to miss a substantial amount of the true surgical margin, we're actually taking the crust off of that loaf of bread. So we're looking at the complete margin all the way around, all the way underneath. And because we're able to do that, we don't necessarily have to start with the standard margins. So, you know, we still have to take skin. We have to remove any residual cancer that we see, but we let the cancer dictate the size of the defect and we let the cancer determine the final post-op defect size. So this is a way that's typically more precise, more individualized. It preserves the maximum amount of healthy tissue. But one key point here with Mohs surgery for any indication is that the tumor should be localized and not metastatic. So the entirety of Mohs surgery really relies on the fact that the tumor is in one place. If there are microsatellites, if it's gone somewhere else, you cannot rely on Mohs surgery for cure, certainly, because you just cannot see it. So you have to rely on the fact that the cancer is localized. So up to this point, I've given you 2 examples of cases where, tissue conservation was really, really key and not removing excess tissue. But I also wanted to bring this case to you. This again is a real patient in my clinic, where the indication was actually that we were concerned we weren't going to be removing enough skin. So this was a really unusual case. It was a woman who came to my clinic with a diagnosis of melanoma, but she tells me that during our consultation appointment, she tells me, she's had this pink, scaly rash all around the area, and she's had it for some time. Now, when I look at that pink scaliness around the biopsy scar, it doesn't look like melanoma. It looks maybe a little eczematous, maybe a little bit of a contact dermatitis to maybe some bandages she's using. That's really honestly what I thought. But she was adamant that it had been there prior to any bandages, prior to the melanoma diagnosis. And because of that, we decided to actually pursue Mohs, even though traditionally I would not have done that in this location since it was in her upper arm. Sorry, so let me finish the story. So this patient actually ended up needing 4 stages of Mohs. Each stage was ½ centimeter. And in total, in order to completely remove this melanoma in situ, it actually required 2 centimeter margins. So this was one instance where, tissue preservation is highly important, but the secondary part, and actually the primary goal of Mohs is always still to clear the tumor. So this was one instance where we actually had to remove more skin than would have traditionally been removed with wide local excision. But as a result, we were able to completely clear her melanoma. So there are challenges with Mohs surgery for melanoma. Mohs surgery is a little bit more tricky compared to, treatment of basal cells or squamous cells, especially, technical challenges. So in order to have reliable Mohs frozen sections, you have to cut these tissues extremely thin. If you have thick tissue, you end up getting a lot of melanocytes all kind of in one area. You can misinterpret the margins. You can misinterpret it as melanoma when actually it's just because you have melanocytes stacked on top of one another. So you have to have extremely thin Mohs sections. And the second part is nowadays, Mohs surgeons will typically, we all recommend immunostains to highlight the melanocytes, the melanoma cells. And so we can use these stains, but these stains were traditionally adopted, validated, tested in dermatopathology labs, kind of the permanent section labs where things are not frozen, things are processed via formalin fixation and paraffin embedding. And so, there have been a lot of protocols that have been developed to kind of utilize these stains in the frozen section world for Mohs, but these stains are still fairly finicky, or they can be. Things like, ambient humidity or just lots of factors can influence how they perform, which can be a technical challenge. And then there's the technical challenge of interpretation. So a lot of melanomas occur on the head and neck. That's also where we get a lot of tan. We have a lot of, freckles, sunspots. And so you also run the risk of overinterpreting some of the melanocytic hyperplasia that can occur around melanomas. So melanocytic hyperplasia just refers to the overgrowth of melanocytes. So the melanocytes, the cells that give us our pigment, have proliferated, but they're not truly cancerous. But it can sometimes be a challenge to differentiate between that versus melanoma. And then because you're adding all these additional steps, so you're adding the immunohistochemistry staining on top of doing traditional Mohs, these can be quite extensive Mohs surgery days. And so what a lot of Mohs surgeons do is actually a modified form of Mohs surgery called slow Mohs surgery. And the reason we do it is because it actually marries the benefits of Mohs surgery, where we're really utilizing it for its complete margin evaluation, with the benefits of formalin fixation and paraffin embedding, where we know that the stains that highlight these cells are just more reliable and considered gold standard. And so what that process looks like for modified Mohs surgery is that we debulk the center of the tumor, and we do submit that for vertebral depth. The reason we do that is because studies have shown us that even in some instances where someone has been diagnosed on a biopsy with a melanoma in situ, once you kind of fully remove the lesion, there may have been an invasive component that was previously not seen. And so we always send, or we do our best to send for vertebral depth. Sometimes on the ear, without a lot of skin, you're not able to, but in general, whenever possible, we try to submit the bulk of the tumor for depth. And then you take the margin and you lay it flat, and you take these horizontal cuts that allow you to see all the way around, all the way underneath. And so that's kind of the Mohs portion. And then you place that tissue, instead of freezing it and processing it via frozen section, you place it in the formalin jar and send it to the, the pathology lab. And so that's why it's called slow Mohs. It's read by the dermatopathologist, and they can still give us on a map, is it at 12 o'clock, 3 o'clock, deeper in the middle, they can still give us orientation. And so, hopefully we clear the patient with one stage, but in certain cases we have to go back. But at least then we won't have to go back around the entire perimeter. We typically only go back in the areas where there is actual residual cancer. Okay. And then once that's done, we repair the defect. And I work with many colleagues as Dr. Georgetown already mentioned, we have lots of techniques to really kind of make sure that defects have optimal cosmetic outcome. So what does the literature say for Mohs micrographic surgery? So the NCCN guidelines for melanoma in situ, again, says to remove margins between 0.5 centimeter and 1 centimeter. The 0.5 centimeter margins came from a 1992 NIH expert opinion consensus. So it's considered a level 5 recommendation. So that's where that number comes from. It's actually a lot of the data from the Mohs world that has informed and updated some of the melanoma in situ peripheral margin guidelines. There's a study out of, just as an example, there was a study out of Pittsburgh where they looked at over 1,000 melanoma in situ cases treated with Mohs with a follow-up of almost 5 years. And they showed that 6 millimeter margins, only removed about 86% of, cleared only about 86% of melanoma in situs. And you really need a 9 millimeter margins to remove up to 99% of melanoma in situs. Another study out of University of Utah where they treated melanomas. These are lenticle malignus, or so still melanoma in situs, typically on the head and neck, treated with slow Mohs, and they showed that 0.5 centimeter margin only cleared 42% of their cases, and that 16% showed invasion. So it's actually some of the Mohs literature that has informed some of the margins that we now use for melanoma in situs. There's another study in 2015. This was a retrospective cohort study of 614 invasive and in situ melanomas treated at an academic center between 2006 and 2012. Now, the vast majority of these patients were melanoma in situ. So 436 were melanoma in situ. And then the second largest group were, again, the thin melanomas. They showed that with the Mohs and immunostaining technique, their local recurrence rate was 0.34%. So this is, this was not a head-to-head study. This is not a prospective trial. This was not a, randomized controlled trial. But historically, that number is significantly lower than with wide local excision. And then this is another, again, academic cohort, 5-year outcomes of wide local excision versus Mohs micrographic surgery. Again, not prospective, but retrospective, looking back at their data and saying at 5 years, how do their patients perform? And so they compared 269 patients treated with wide local versus 154 patients treated with Mohs. Again, this is melanoma in situ, and their recurrence rates were lower with the Mohs surgery, about 2% compared to about 6% for wide local excision. So the vast majority of the literature is on melanoma in situ, but there have been some with an early invasive melanoma as well. This was a study in 2019 looking retrospectively at AJCC8 stage 1 melanoma patients treated with wide local excision versus Mohs surgery. And the data was pulled from the National Cancer Database. And so you can tell that the vast majority of patients were treated with wide local, so 67,000 patients compared to about 3,000 patients treated with Mohs surgery. So it is a more limited subset of patients that received Mohs. And you can probably imagine that the subset of patients may be different from the get-go, those who received Mohs versus those who received wide local. But after controlling for a lot of these variables and propensity matching, meaning trying to match the cohorts as closely as they could, they still were able to demonstrate that patients treated with Mohs surgery had a modest improved overall survival compared to the wide local excision group. At the very least, what I would say is that we don't have, right now, the literature supports that Mohs surgery is non-inferior. I don't think that it is the standard for thicker melanomas, but in select instances, it is another tool in our toolbox. And so just in summary, Mohs surgery and slow Mohs, the modified Mohs surgery, offer complete margin evaluation. I think, in our tumor board conference, we considered the role of Mohs surgery, especially for specialty sites on the face, hands, nails, feet, genitalia, and for poorly defined clinical borders. And there is literature to support the non-inferiority of Mohs surgery for melanoma in situ and early invasive melanoma. Thank you so much for your time.
Thank you, Dr. Deng. That was really great. So now we're going to have a panel discussion and invite all the speakers in this first session to turn your cameras on and open your microphones. And we'll also have Dr. Terziak join us. And to moderate this session, my colleague, Dr. Jeff Gibney, will be the moderator. Dr. Gibney did his fellowship training in hematology oncology at Yale, and then spent some time in the melanoma program at the Moffitt Cancer Center in Tampa before coming to Georgetown and MedStar Georgetown University Hospital in around 2016. He's currently leads the melanoma and skin cancer disease group within MedStar and Georgetown Lombardi Comprehensive Cancer Center. And also, in something he'll talk about later when he gives a lecture, also leads the solid tumor cellular therapy program at Georgetown Lombardi Comprehensive Cancer Center. And so I encourage the audience to put your questions in the question and answer part of your, I think there's a few there already, of your Zoom field, and also the panelists to ask each other questions. Dr. Gibney?
Well, thank you, Dr. Atkins. And this has been a wonderful series of presentations so far. And I certainly learn things every time I'm participating in this and enjoy it. So I hope everyone is doing the same. And we have a really nice group of panelists here, ranging from epidemiologists to dermatologists to surgeons, and to Mike Atkins and myself, who are medical oncologists. So I think we all bring something different to the discussion here. So this is hopefully a very good opportunity for us to touch base on a number of topics and have different perspectives. We would like to get as many questions from the attendees to have the engagement and answer questions that are most relevant to the participants, but we're certainly able to cover some additional topics. And I think starting off, we can go to the question and answer panel. There's actually maybe more of a little bit of a technical question that was posted early on. Dr. Atkins, I see you have your hand raised. I don't know if that's also weigh in on the panel discussion, or just want to make
Yeah.
sure you're there.
Yeah, no, I have a question when the appropriate time comes.
Look, we will certainly get to your question.
Thank you.
So let's start off with the first question that came from the panel, and this might be more geared towards our dermatology colleagues for Dr. Ajebo and Dang. So this is about atypical mole syndrome, and the question is, does science say about the typical number of primary melanomas that a person will develop? And I think just as the panel, maybe you can remind us what atypical mole syndrome is, what it looks like, and what this means for patients.
Sure. Atypical mole syndrome is patients who have 5 or more atypical moles and with no history of melanoma, with no personal history of melanoma. So for a person with 10 or more atypical nevi, the reported relative risk for developing melanoma could be as high as 32-fold. However, melanoma is a multifactorial disease. So it also, the environment also contributes. So a person who lives around the equator doesn't have, have higher risk of, getting melanoma than a person who lives away from the equator. So because it's multifactorial, it's hard to say how many melanomas a person would develop. However, definitely having, having one atypical mole could increase a person's lifetime risk of having developing a melanoma by at least 6%. So the more atypical nevi a person has, the higher risk of developing melanoma in general.
Well, thank you. That's a great description. And Dr. Dang, there's another quick question that came in related to this. Maybe if you could describe what a nevi or nevus is, just from the technical standpoint. I think there was a little confusion of mole versus nevus versus some of the other terms we were using. And then maybe you can comment on when you do have a patient that you identify that has an atypical mole syndrome, how do you manage them for surveillance?
Yeah, so I guess let's start with just nevus or mole. So we're using those terms interchangeably a little bit. And so generally when we are referring to nevus, we're saying mole. So think of those as the same thing. And so that should be differentiated from some of the other brown spots that can show up on our skin, especially, seborrheic keratoses, which are completely benign, freckles, which, are they can sometimes lighten during the winter time and kind of darken during the summertime, and then sunspots. So sunspots, again, these, I'm trying not to get too technical, but they're not true moles. So when we talk about nevis, an atypical mole syndrome, we're referring to true moles. And so that is a group of melanocytes that are, hopefully benign, but they can turn cancerous, and when they do, we call them melanomas. Sorry, that was the first question. And the second question, surveillance. Yeah, Dr. Ajebo, would you like to take that?
Sure. If it depends. If a person has a lot of atypical nevis, 50 to 100 nevis, yearly skin check would be a very good idea. And then if a person is diagnosed with melanoma, then we increase the surveillance time to every 3 months for the first 2 years. Then it goes, to every 6 months. And then if we don't see any melanoma, then we go to yearly skin check after the first 5 years. So for a person who is, who has a pale skin and risk factors include easily burning, it's good to have a full body skin check at baseline, and then based on what we see, we would recommend a yearly skin check, versus what, based on what we find out, that's how we decide. Yeah.
Okay. Well, thank you for the very thorough responses. And maybe we move on to the next question that came in. And this one is, can you talk about genetic counseling and testing for melanoma? So this does come up, especially even in the later stages when we see patients with more advanced melanoma. And this covers, I think, whether you're entering the clinic for dermatology, surgical oncology, or medical oncology. And I don't know, Jonathan, if this comes up in your panel, maybe we could start off the discussion and we can expand it from there.
Yeah, I'm happy to just kind of go over it from the surgical perspective. I feel like we typically rely quite heavily on our medical oncologists whenever it comes to the actual DNA sequencing and genetic variants that can exist in terms of guiding not specifically surgery, but oftentimes which medical treatments are more appropriate and kind of which pathways to follow in the adjuvant, or meaning the kind of post-surgical setting, or in the neoadjuvant setting, starting ahead of surgery with a specific medical treatment before going on to surgery. There are different genetic markers that we can look for with melanomas that can help to guide this. A very common one is a BRAF mutation, which is a mutation that can guide certain immunotherapy regimens. Dr. Atkins and Dr. Gibney could do a much better job probably than myself in terms of talking about MEK pathway and tyrosine kinase inhibitors and all the other kind of drugs and how they relate to these specific DNA findings within the melanoma, though.
Thank you, Dr. Georgetown. And I would agree with you. There are mutations or genetic abnormalities that we commonly find in melanoma that are acquired, and there's some that are inherited. And we do really focus on both sides. And we have the discussion of potential referral to a genetic counselor when we think there might be something that's outside of the usual pattern. I think most often when we have a young patient, typically under the age of 35, if we have a patient that has multiple melanomas that are being diagnosed in a window of time, and then a strong family history of multiple melanoma or other cancers, including personal history if you have other cancers, that we sometimes see patients develop breast cancer, prostate cancer, pancreatic cancer, and melanoma. And sometimes these are all tied genetically. So when we see these flags, we do start the conversation for genetic counseling. I think within our clinics, though, we typically do not do a lot of the genetic testing unless we're using it for treatment. And we refer off to our colleagues. In fact, Dr. Rapasuan is one of our melanoma medical oncologists, as well as genetic counselors that will often see our patients to help with this as well. So Dr. Atkins, I know you had a question at the beginning. Maybe we move on to that.
Yeah, so this is for Marcelo and Dr. Terziak. So you all talked about a digital approach to addressing tanning addiction, but I'm wondering whether you've learned from some of the other addictions, whether there are medicines that also could be considered, and whether there are studies with those, and what you think about potentially some of the GLP-1 inhibitors might play a role in this, since they tend to induce all types of cravings.
Well, I'll take part of that question, Mike. It's a great question. So we've learned so much from other addictions that we're trying to apply to this particular problem. It's not always a great fit. Some will translate more than others. One of the things that we learned most importantly in the work that we did was how closely associated the phenomena of indoor tanning, particularly among young women, is to other mental health challenges that people commonly face. So I'll use the example of depression. Depression was sort of a major third force in many of the largely untreated young women that we saw in our study. So I think for the purpose of this discussion, the quickest thing that comes to mind would be medicines that would possibly aid in the alleviation of treatment for depression. I'm a psychologist by training, and any of our participants in this study who scored particularly highly on our screening for depression, I had a chance to speak with all of them as part of our research process. and regularly made referrals for those study participants back to their care provider, if they had one, or to a community provider, specifically to be able to address their mental health burden. I think for a lot of young people, particularly coming out of the pandemic era, for example, the mental health challenges that we face are just pretty astronomical. And this sort of is a important hidden problem in these individuals that I think needs greater attention.
Great. Fantastic response there. And I think maybe we have time for one last question before we head into our break. And I don't believe I've seen any new questions come up in the question and answer chat. Actually, I do see one that did just come in. Can slow Mohs be used for patients that are stage 4 with multiple recurrences as a mucosal melanoma in the same area where the margins were cleared previously for tumor removal? So I think, Dr. Dang, this one is probably directed largely to you. So I think it's where there's multiple recurrences of in maybe a local regional disease fashion where either the cancer hasn't been cleared easily and keeps coming back, or has been cleared but does seem to still come back in very similar region.
Yeah, so I think, I think each case is individual and unique, and I would suggest that if someone is running into a specific scenario to seek, one-on-one individualized, recommendations. What I can say is that Mohs surgery has been used in recurrent localized melanomas. So in melanomas that maybe previously underwent surgery and has come back just in the skin, and the data has been supportive of that. I worry about any melanomas that have metastasized or, with micrometastases. That's the thing that I would worry about. Again, Mohs surgery, that complete margin evaluation relies on the fact that the tumor is all in one piece. And so that if we see a clean margin, we should be able to say that we've removed it. If that cancer has spread, has gone somewhere else, we just cannot see that. So I would say it's a good question. It has been used for recurrent melanomas, but I caution the use in more advanced regional melanomas.
Yeah, I can just add a quick chime in, and that question was on mucosal melanoma. So we see quite a few mucosal melanomas in the head and neck region. We see it in the nasal cavities, sinus cavities, oral cavity, oropharynx. It's a completely different beast than cutaneous melanoma. The lymphatic supply of the mucous membranes is different than skin. The surgical resection in mucous membrane orifices is different than skin. The reconstruction is different. So it's melanoma, but it's quite a different entity than cutaneous melanoma. And in the head and neck region, we still will operate, though more frequently nowadays, especially in very advanced mucosal melanomas, we're relying much more heavily on immunotherapy and our medical oncology colleagues to really help patients with advanced mucosal melanomas.
Thank you, Dr. Georgetown. No, I would agree. We lump a lot of the different subtypes of melanomas into one big category, but the biology and management does vary a bit. We actually had a couple more questions show up. Maybe we try to cover these quickly and then we can head into our break. I think that starting off with maybe the last question, for those who are at high risk for developing melanoma, and I think folks in general, what sunscreens do you recommend to use to help protect against melanoma? This sounds like a perfect dermatology question.
Okay, I can go ahead. So with the sunscreens, the ones that are really good are the mineral sunscreens that have zinc oxide or titanium oxide in them. And SPF of 30 or better would be great. And in addition to sunscreens, also wearing wide-brimmed hat and UV-protected long-sleeved shirt would be great too.
Dr. Dang, anything to add on your viewpoint for sunscreens?
Yeah, I will admit that I differ a little bit in my SPF recommendations. So I go up to 50, but I see a very special cohort of patients who've probably already had skin cancers and melanoma, so they're already high risk. So I differ. Our official Academy of Dermatology guidelines are SPF of 30 or higher, but essentially every study that's been done has shown that people in real world scenarios apply about a quarter of what they're supposed to apply. So they're not truly getting that SPF. So for those reasons, I do tell my patients to go up to at least 50 or even higher if they're going to be near the equator. The key is to, reapply. I think people remember to apply first thing, but through the course of the day, you sweat, the products break down, you need to be applying every 2 hours. If you're going to be in the water, you should be applying every hour. So I would just say, enjoy life. You need to be out, but yeah, sun protective clothing, avoiding the high noon sun. Those are all strategies. And ultimately, the best sunscreen is the sunscreen that you're going to use, ones that don't burn your eyes and that you don't mind putting on. So we love our mineral sunscreens, but ultimately find one that you like. That's broad spectrum, SPF 30 or 50. And yeah, that's the most important.
Thank you, Dr. Dang. And just a quick follow-up to that. If you're applying your sunblock frequently, every hour or 2 hours, if you're in the water or whatnot, is there a true advantage to having a SPF above 50?
That's a good question. Well, so again, there have been 2 studies, and one was done at the beach, one was done on the ski slopes. They gave people 50 versus 100, and they showed, again, in real world scenarios, people, you just don't put on enough, or you don't put it on in the frequency interval that you should, and they were able to show that even within 2-3 days, split body study. So the patient put one on one side, one on the other. SPF 100 was better than SPF 50.
Thank you, Dr. Dang. And there was an additional question that came up, and I know Dr. Atkins had answered it in the answer and question option in our system. But I guess just to briefly touch base on it, but when a patient's been diagnosed with stage 3 melanoma and has had multiple immunotherapy treatments, multiple surgeries, this is certainly a very high-risk scenario where we do recommend close follow-up with imaging studies usually to monitor for recurrence, including in lymph nodes. So we typically work with our surgeons and our medical oncology colleagues to have a surveillance plan in place. Often for stage 3, that means seeing providers and scanning every 3 to 6 months, depending on where you are in that course, and then it does space out from there. So I think with that, we've run over a little bit into our break time. We should probably pause here, and we
yeah, I just wanted to take it over,
yes.
Jeff, and thank the panelists for your participation. Give people a 15-minute break, so come back at 10:50 for the second half of our symposium, which will focus on systemic treatments of the whole body for melanoma, where there have been some major advances over the past 10 to 15 years, and Dr. Gibney will chair that session. Thank you all.
Welcome back, everyone. Hopefully you had a few minutes for a break, and thank you for participating in our morning session. If you're just joining now, I'm Jeff Gibney, one of the medical oncologists at Georgetown, and joined here by our colleagues from Georgetown, who are part of our melanoma and skin cancer program. We had a discussion on management of early stage melanoma and risk factors, including a very exciting talk on the impact of tanning bed use. And we are shifting gears now towards more advanced melanoma and the management of it. And we will also have a panel discussion at the end of it. So to our attendees, we would love for you to enter questions as you think about them and as they come up. We will very likely plan to address them at the end of the session during the Q&A. But if there is a question that comes up that's very specific, we might be able to answer a manual response in the Q&A panel. So please feel free to put those up when they come up during the presentations and not wait to the end. So the first speaker for our second half of the session is Dr. Michael Atkins. And I know we already did an introduction for Dr. Atkins, but just wanted to briefly touch base that Dr. Atkins is one of the really mover and shakers of the melanoma field and immunotherapy, and has had a pretty impressive career developing immunotherapy from starting off at Tufts University and his, I think, first job at Beth Israel Deaconess in the Harvard School program, where he led the melanoma and renal cell programs, co-PI in the SPORE research program, and in 2012 joined Georgetown as the deputy director for Georgetown Lombardi Comprehensive Cancer Center in DC. He's also the William and Scholl Professor and Vice Chair of the Department of Oncology at Georgetown University Medical Center. He leads the immunotherapy working group and chairs the investigator-initiated trial steering committee at Georgetown, where we develop our own research protocols. And his research focus has been on immunotherapy for melanoma and renal cell carcinoma with regards to response and biomarkers and toxicity management. If you were to look him up in PubMed, you'll find probably over 500 articles that he's participated in. He participates in the Melanoma Research Foundation at multiple levels, and obviously is a very important leader in the field. So with that, I'll pass over to Mike Atkins for his systemic therapy and melanoma talk.
Thanks, Jeff. Can you see my slides okay?
Yes, we can.
Great. So I'm going to talk about systemic therapy for metastatic melanoma with a 2024 update. And these are my disclosures and potential conflicts of interest. And so advanced melanoma historically was considered a bad disease. As a matter of fact, people said this was the cancer that gives cancer a bad name. And that was because there was the mortality or death rate was increasing compared to other cancers. The median survival was 6 to 9 months in most studies, and less than 10% of patients lived 2 years. And for therapy, there were few effective medical options prior to 2011. Some of those, such as dacarbazine or interleukin-2, had limited or no effect on overall survival. High-dose IL-2 had significant toxicity, and the number of positive randomized trials comparing one treatment to standard of care was 0. And these were the survival rates by stage. We've been hearing about stage 1 and stage 2, which are localized melanomas. We'll hear from Dr. Rapaswan about stage 3 melanoma. I'm going to be talking about stage 4 melanoma, which is this blue curve down at the bottom. And in 2011, you can see that by 1 year out, half the patients were deceased, and by 10, 15 years out, less than 10% of patients were alive. So a very bad disease. But since then, there's been a revolution in the treatment of stage 4 melanoma, which includes all these drugs on the top of this timeline, which are immunotherapy treatments, and I'll be covering some of those, and then all these treatments here on the bottom, which are targeted therapy treatments. So targeted therapy treatments primarily target a mutation within the tumor, not within people, in the protein called BRAF, or a gene called BRAF that creates a protein called BRAF that can lead to proliferation and survival of the tumor. And through great research, this mutation was identified, and then drugs such as vemurafenib, dabrafenib, and encorafenib were identified that could block that mutated pathway. In addition, it was shown that drugs that block that pathway at a second level, trametinib, cobimetinib, and binimetinib. So a double block in this pathway added additional benefit. And the immune therapy part of it was essentially showing that when we look at the immune cells in the tumor microenvironment, they were primarily exhausted, tired out from trying to kill this cancer. And the cancer was prevented from being killed by primarily checkpoints, including PD-L1 expression on its surface, binding to PD-1 on these exhausted T cells. And if you could block this pathway, you can reinvigorate these T cells, so now they can go and kill the tumor. And that's what immune checkpoints are about. And so the power of a single agent BRAF inhibitor is shown by this slide. This is a patient with widespread cutaneous metastases from melanoma. The skin is grayish and he's a little bit thin, having lost weight. And within a few months of taking vemurafenib, most, if not all, of these lesions had disappeared, and he had become more robust. But unfortunately, that benefit was short-lived, and somewhere between 6 and 9 months, those tumors started to come back. But there were 3 studies that looked at combinations of these BRAF and MEK inhibitors compared to vemurafenib, and each showed on this blue curve a benefit compared to single-agent vemurafenib on the red curve, with about 40 to 50% of patients having a delay in their progression and producing improved overall survival. So it was hard to have any difference between these combinations, which are all approved by the FDA based on efficacy. And so we choose these regimens based on things like toxicity and ease of administration. And dabrafenib and trametinib is a major side effect is fevers. You'll hear more about this from Kelly Gardner. And for vemurafenib and cobimetinib, it's photosensitivity. And encorafenib and binimetinib has less of those toxicities. It allows for continuous dosing, doesn't require refrigeration. The BRAF part of it has a longer half-life, so it can be given once a day. And so that has become our preferred option for many patients, while for patients with brain metastases or patients with stage 3 disease with a risk of recurrence, as you'll hear from Dr. Rapisawan, it's dabrafenib, trametinib that are FDA approved. And although the response rates are high and the duration of response is suboptimal for these BRAF MEK inhibitors, there is a group of patients that tend to benefit in a long-term way, and that's patients with slower growing disease with a lower LDH and small tumor burden involving less sites of disease, where somewhere around 40% of those patients will remain progression-free long-term all the way out to 4 years, and about half of those patients may actually be cured by BRAF MEK inhibition. But the true revolution in the treatment of stage 4 melanoma comes from immunotherapy. And to set the stage for this, we know that all tumors, all cancers have mutations, and those mutations form abnormal proteins which can be recognized by the immune system as foreign and lead to the destruction. Same way your immune system may attack a virus. And thinking about, and the development of immunotherapy has changed the way we think about cancer in general. The host immune system is now thought of as the dominant active enemy faced by a developing cancer. And all successful cancers must therefore have a way to evade or disable the host immune system. And we'll talk about checkpoints being the major way that many cancers do that. And immunotherapy treats the immune system so that it can once again attack the cancer. So it's not directly attacking the tumor, but restoring the activity in the immune system. And because the immune system can broaden and deepen over time and attack multiple foreign proteins at the same time, it can eliminate the last tumor cell producing cures, which are manifest by flat plateaus on these survival curves that I've been showing you. So there were two different type of major checkpoints, one being CTLA-4, which is blocked by drugs like ipilimumab and tremelimumab, and another called the PD-1 pathway blockers, which are blocked by the drugs shown here. And Dr. Hanjo, whose picture is shown here, won the Nobel Prize in 2018 for discovering this pathway. So it turns out that this anti-PD-1 therapy is active in many different tumor types, probably 21 different tumor types. But the ones where it's most active are the ones that have the most mutations, with melanoma being here at the right because of extensive sun damage having the most mutations. And when we started to use drugs like pembrolizumab or Keytruda in patients with melanoma, and this is a CT scan of a patient with a large melanoma metastasis in their chest and also in their liver, and they had progressed on a lot of prior therapies. And when they received pembrolizumab, a year later, their disease was essentially gone. And now 10 years later, or 11 years later, this patient remains alive. So this led to the approval of pembrolizumab for treatment of metastatic melanoma in 2014. But one of the real advantages, it turns out to be combining anti-PD-1 with anti-CTLA-4. And anti-CTLA-4 was discovered by Jim Allison, and he also won the Nobel Prize for this discovery in 2018. And if you want to know more about this discovery and the first checkpoint, there was a movie that came out called The Breakthrough, which is available on Netflix, and it's quite compelling. And I encourage you, if you're interested, to download it and watch it sometime. But this combination therapy of blocking CTLA-4 and blocking anti-PD-1 with drugs called ipilimumab and nivolumab, or as you may hear on television, Opdivo and Yervoy, showed improved progression-free survival compared to nivolumab alone. Here you can see out at about 6.5 years, of 6% more patients remain progression-free, 7% remain alive. And we're now starting to talk about melanoma-specific survival because patients living a long time are actually dying of other things. And so 56% of patients at out 6.5 years are free from death from their melanoma. Now, these combination immunotherapies, as you'll hear from Kelly Gardner, have toxicities, and I think the combinations, some patients are afraid of these toxicities, but from my perspective, we have to watch patients closely, and the side effects show that we've done our job of activating the immune system. And if you look at patients who have toxicities from immune therapy, they tend to do better than the group of patients shown here in yellow who don't have any toxicities. And if you have toxicities that require steroids and other drugs to control them, those patients seem to do the best in terms of controlling their cancer. And so in 2011, this was the survival. And with the approval of BRAF MEK inhibitors, we could see a splaying of the curve And with the approval of nivo-ipi, we could see a raising of the tail of the curve. And we asked the question in 2015, which is preferred? And because patients would have access to both of these treatments, is there an optimal sequence? And so to answer this question, we launched a study called the DreamSeq trial, which took patients with metastatic BRAF mutant melanoma who had received no prior treatment and randomized them to receive either combination immunotherapy in the front line or arm B, continuous dabrafenib, trametinib, BRAF targeted therapy. And if they showed disease progression and met eligibility criteria, they could cross over to the alternative treatment. And so because we thought these curves would cross, as we showed on the last slide, we chose our endpoint as 2-year overall survival, estimating 70% for the immune therapy first treatment and 50% for the targeted therapy treatment. And at the fourth interim analysis by a committee that looks at the data without us knowing about it, the committee saw, with only 59% of patients being 2 years out, that there was a dramatic difference favoring the immunotherapy first treatment and recommended halting accrual and releasing the data. So this was the data that was released. You can see the curves actually did cross, and at 2 years out, there was a 20% difference in 2-year overall survival favoring the immunotherapy first treatment, with rates that were very similar to what we had predicted. But we also saw that there was a group of patients who tended to do worse with immunotherapy early on. And a lot of our ongoing research is identifying those patients who had more aggressive disease and for some reason didn't get their targeted therapies. And we're trying to not only identify those patients, but figure out how best to treat them. So why was the nivo-ipi initial therapy better? Well, for several reasons. The overall survival benefit was seen in all clinical subgroups, and nivo-ipi resulted in more durable and ongoing responses, 88% versus 48% remaining in response. And then while the targeted therapy was equally active in the first and second line, nivo-ipi was less active, having fewer responses and shorter progression-free survival when given after targeted therapy. And finally, there were more isolated progression of disease in the brain and worse outcome for that disease with targeted therapy than with nivo-ipi. So one thing that we found and explains why that fourth point is that immunotherapy is as active in the brain metastases as it is in systemic disease. And if you want to know more about this, I can encourage you to read this book, The Neuroscientist Who Lost Her Mind, by Barbara Lipscoe, one of my patients who happened to be in charge of the brain lab at the NIH. And she gives a great story about recovery from melanoma and melanoma involving her brain. Maybe someday this will be a movie, and if it is, I want Tom Hanks to play me. So combination immunotherapy achieves many patients' preferred outcome. The treatment often ends either because of toxicity or electively, and the benefit persists. And this creates something called treatment-free survival, which has turned our immunotherapy, our melanoma clinics, into virtual travel agencies, because patients freed from their melanoma disease and free from their melanoma treatment have a second lease on life and are traveling the world, hitting things on their bucket list and going to milestone family celebrations. And so we don't call them survivors, we call them thrivers. So how can we improve the outcomes for targeting for immune therapy? And possibly we can do that by targeting some other inhibitory checkpoints which are on the surface, one of which might be something called LAG3. And there's a drug called relatlimab that blocks LAG3 and can restore T cell function. And in studies that were done a few years ago, where Nivo anti-PD-1 plus Rela anti-LAG3 was compared to Nivo monotherapy, you can see that there was an improvement in progression-free survival and an improvement in overall survival, somewhat similar to what's seen with Nivo-Ipi, and patients generally tolerated it better than the side effects of Nivo-Ipi. And what we saw recently at our ASCO meeting was a triple combination of Nivo, Rela, and a CTLA-4 blocker, ipilimumab. And this showed also a pretty good PFS and overall survival. And when you compared that benefit to the doublet combination, so this was a small study, non-randomized, you could see that there was higher progression-free survival at 36 months than was seen with these other two combinations, and higher overall survival at 48 months. And so we, for the most part, give combination therapy to our patients with metastatic treatment-naive melanoma, and we'll be studying triple combinations in the future. So our next steps are to determine which patients to treat with particular anti-PD-1 regimens now, try to come up with treatments for checkpoint inhibitors and targeted therapy-resistant disease, and Dr. Gibney will be talking about that in his presentation. Moving treatments to the adjuvant and neoadjuvant settings, and Dr. Rapaswan will be talking about that in his presentation. Predicting and managing side effects better, and nurse practitioner Gardner will be talking about that, as well as we'll hear some about improving therapy for patients with variant melanomas such as uveal melanoma and acral and mucosal melanoma. So thank you very much. And I'll close by saying our goal should not be simply to turn melanoma into a chronic disease. We should be striving to make melanoma a curable disease. And with the advances of the past decade, that dream is becoming a reality. Thank you very much. I'll stop sharing and turn it back over to Dr. Gibney.
Well, thank you, Dr. Atkins. Fantastic presentation and very inspiring that we've made a lot of progress and certainly a lot to come. So let's move on to our next speaker, Dr. Rapaswan. He's a leading medical oncologist specializing in melanoma with a particular focus on uveal melanoma. He's a leading investigator, initiated trial that is a phase 2 multi-center trial investigating the combination of nivolumab and ipilimumab, two of the drugs we just discussed, in patients with high-risk uveal melanoma. The aim of this research is to enhance therapeutic strategies and improve outcomes for patients with this aggressive form of eye cancer. Dr. Rapaswan recently presented significant findings of this research at the 2024 ASCO annual meeting. And certainly this is contributing to the advance of melanoma treatment and patient care, a very exciting area of development. So with that, I will pass it over to Dr. Rapaswan for his talk.
Thank you, Dr. Gibney. To take up on what Dr. Atkins mentioned, yes, we are changing melanoma from a chronic disease to a curable disease. We actually had a session with Dr. Jed Wolchok and Philippa Corey at the 2024 annual meeting regarding daring to cure melanoma. If any of you are interested, it is a very fun and interactive event available online. So this is my disclosure. So what I would like you to understand, at least to take from this 15 minutes talk, would be, to understand the risk of recurrence in high-risk melanoma, and then understand your adjuvant melanoma treatment option. Although this is not like quite on prime time yet, but I would like you guys to be informed about the neoadjuvant approach that would likely be coming, hopefully mostly in the clinical trial setting. And lastly, but not least, the high-risk uveal melanoma adjuvant treatment option. So why is it important to understand the stage of melanoma? I think like everyone before me have already talked about it. The higher the stage of melanoma is, the higher risk of recurrent disease from a stage 2, 3, and 4. And what it matters is patient with a higher stage, especially like a late stage 3, will have like higher risk of recurrence, as you see in this survival curve here. And the subdivision of stage 2 and stage 3, for example, is based on the presence or absence of a palpable or clinically apparent lymph node, or the size of the primary tumor, or the presence of ulceration with the size of primary tumor. The worst prognosis in the stage 3 would be stage 3D, which their 5-year melanoma-free survival is around 20, about 30%. And for stage 2B and 2C disease, their risk of melanoma reoccurrence is a little bit higher than stage 3A. Then to move the field forward from the metastatic setting, that we know that the immunotherapy combination or single agent or even targeted therapy with the dabrafenib, trametinib, or encorafenib, binimetinib, or essentially BRAF MEK inhibitor can improve the outcome or control or even cure patient with melanoma. We move the field forward to the like earlier setting to try to reduce the risk of melanoma reoccurrence or even overall survival. And so far as of 2024, we have this list of immunotherapy and targeted therapy that are available to patients with localized melanoma. At a different level. For example, for stage 3, we have an option of either the dabrafenib, trametinib for patient with BRAF mutation, or the single agent immunotherapy, either pembrolizumab or Keytruda, or nivolumab or Opdivo. For the talk purposes, both of them are interchangeable in terms of the class action. Ipilimumab has been used in the past, but we have been using it less and less in the adjuvant setting. Here the survival curve here explain like how using different adjuvant treatment in patient with high risk of melanoma recurrence can help patients preventing or reducing the risk of melanoma relapse. For example, in this study, the COMBI-AD, the study used dabrafenib and trametinib, which is a BRAF and MEK inhibitor that Dr. Atkins has previously mentioned. It improved the 5-year risk of recurrence from 36% to 52%. And then like for the Keynote 054 and Checkmate 234 that use either pembrolizumab or nivolumab versus placebo, it also show very similar trend of improvement of the relapse-free survival at 5 years from 38 to 39% to about 50 to 55%. That is a significant improvement in saving patients from dealing with the stage 4 melanoma. And this is to recap the finding that we just mentioned earlier. So speaking about stage 3, it's going to be difficult not to mention, honorarily mention about the treatment of stage 2B and 2C melanoma, as I presented to you previously that, stage 2B and 2C melanoma also has an increased risk of melanoma reoccurrence in 5 years and 10 years. And the field have been looking into the treatment option, and the results of this study, the Keynote 716, showed an improvement of the relapse-free survival or recurrent-free survival at the 18-month with numerical and statistical improvement of patients who received the adjuvant pembrolizumab as opposed to placebo from like 7% to 85% at 18 months itself. So this has recently been a standard of care for patients with 2B and 2C melanoma. And as of 2024, it's going to be somewhat wrong not to mention about the advancement of the personalized mRNA vaccine as an adjuvant treatment in combination with anti-PD-1 therapy, pembrolizumab. Here, our own Dr. Gibney is also a part of the study as well. So how does it work here? We use the patient's tumor itself to extract the DNA of the tumor and look into a part of the DNA that we can use as the segment of the nucleic acid or like a part of the protein that the immune cell or the T cell of our body can recognize, and we we then manufacture it as the like mRNA vaccine to re-inject it to our body. So this is this vaccine is from your own tumor itself. So that's why we call it personalized. And by doing so, with the stimulation of the anti-PD-1 to block the inhibitory signaling from your T cell so that your T cell can be activated against this antigen that was present in your tumor, we could improve the chance of patients being free of cancer as compared to the pembrolizumab or the Keytruda alone with the 18 months relapse-free survival, which means like in 18 months, the chance of you being free of melanoma reoccurrence has improved from 62% to close to 79%. So that's the things that we keep looking and keep working on, like pushing the boundary or pushing the envelope to improve the cure rate of our patient with melanoma. Then moving on, like, we mentioned about how the adjuvant neoadjuvant therapy works. I took it from Dr. Sapna Patel, who is currently a chair of the cancer research at the University of Colorado. He just moved from MD Anderson Cancer Center. This slide presentation like summarized like the idea of adjuvant neoadjuvant approach really well. So we know that PD-1 inhibitor blockade improve the anti-tumor activity of the T cell that have been in contact with the cancer. And by using the surgery to resect the tumor followed by the adjuvant anti-PD-1, improve the chance of our patient being free of melanoma reoccurrence. And by doing so, giving adjuvant anti-PD-1 can also, activate the immune response at the site of micrometastases or, those melanoma cells that have like split off from the primary tumor to other distant sites to kill those. So we can prevent or reduce the risk of distant reoccurrence. On the other hand, by giving the anti-PD-1 before surgery can also induce immune response from a larger population of the immune cell that resides around the tumor itself, and that by giving it before surgery, we can both induce the response from the primary, from a local site, for example, the lymph node, or the distant site, for example, the lung or the other places. Even before resection. So in that way, we use the immunotherapy before surgery. We could expand the repertoire of your immune cell so that we have a variety of immune cell that can detect different kind of antigen that is or different kind of tumor antigen in your melanoma itself. And this can also, hopefully attack the melanoma better from the both local and micrometastasis size. And this led to the clinical trial using the neoadjuvant or plus adjuvant pembrolizumab in patients with stage 3B to stage 4 melanoma, as compared to the just adjuvant therapy alone in the study that is called SWOG 1801. So patients in this study would be randomized to 1:1. One will receive, like I mentioned, neoadjuvant followed by adjuvant approach after surgery, and then the other side would only get surgery followed by adjuvant treatment. And we saw that patients who had received neoadjuvant followed by adjuvant approach did better in terms of the chance of being cancer-free at 2 years. As compared to patients who receive only adjuvant therapy alone, with a 72% versus 49%. This is quite significant. And then the response or the chance of being cancer-free also correlated to the depth of response. For patients who had the cancer regress to less than 10% of the viable cancer cell, they tend to do much better than people who had like lower level of response from the neoadjuvant treatment, which means like, you know, immunotherapy before surgery. And then we mentioned about the SWOG 1801 with the neoadjuvant pembrolizumab, and so it's gonna be wrong for me not to mention about these new advancement, which is the neoadjuvant ipilimumab and nivolumab versus adjuvant nivolumab alone. This was presented in at the 2024 ASCO plenary session presented by Dr. Christian Blank. So the design of the study is similar, but it's a little bit different from the SWOG 1801. We use patient who had they enrolled a patient who had the macroscopic stage 3 disease. And they randomized patient into 1:1. One group would receive 2 courses or 2 cycles of neoadjuvant ipilimumab with nivolumab, followed by total therapeutic lymph node dissection. And the other group will receive upfront therapeutic nodal dissection, followed by adjuvant therapy. For a group that received the neoadjuvant approach, after the therapeutic nodal dissection, if they had a major pathological response, which means the tumor regressed more than 90%, they would not receive any adjuvant therapy. And for people who had less than major pathological response, they will receive 11 more doses or 11 more cycles of adjuvant anti-PD-1, or for people who have BRAF mutation, they will receive an adjuvant dabrafenib trametinib or BRAF inhibitor for a total up to 1 year. And the results show very similar results to the SWOG 1801, that at the 12-month landmark, the probability or the proportion of patients being free of relapse in the neoadjuvant group is 83.7% as opposed to 57%. This is a whopping almost 25% improvement. And the finding also hold true regardless of whether a patient had a BRAF mutation or not. As you can see here, 83.5% versus 52.2% in the BRAF mutation versus 84% as opposed to 62% in the BRAF wild type. And we see that patient who had major pathological response, which, like I mentioned earlier, patient who had like the viable tumor, less than 10%, had consists of 59% of the population who received the neoadjuvant treatment itself. And the depth of response also correlates to the chance of patient being free of cancer at 12-month landmark at close to 95% on both patient who had major pathological response or near CR or the CR or complete response itself. This is a breakthrough. This is very significant in our melanoma community because although this is not gonna be quite ready for prime time. I foresee some people would start using it off, clinical trial, but the significance of this is it's gonna keep pushing the field forwards into trying to cure the patient with melanoma and spare them from more doses of adjuvant immunotherapy itself. But this is not the end of the story. There will be more clinical trial to explore whether the one agent is better than two agents. For the neoadjuvant clinical trial, we at Georgetown still have the neoadjuvant approach in by using the anti-PD-1 immunotherapy with a novel checkpoint inhibitor, anti-TIM3 inhibitor, followed by surgery. So we are still accruing patient, although the accrual probably will come to close sometime soon in the near future. So moving forward to the uveal melanoma itself, although it's a rare melanoma, this is the most common primary ocular malignancy in adults. And the risk factor is mentioned here in the slides, and primary treatment for the uveal melanoma would be either to enucleate, which is removal of the eye and the tumor itself, or using a brachytherapy, or we use a radioactive seed to plant it into the eye, just like outside of the eye that we call sclera, to try to radiate and kill off the cancer cell. However, there are a group of patients who are at risk of the recurrence, especially for patients who had a large tumor with the abnormal genetic makeup inside the tumor itself. We measure it by using the RNA transcriptome or using the cytogenetic to look at the presence or the loss of one of the chromosomes, which is the chromosome 3, or using the calculator itself to define their risk of being cancer-free at 3 years by less than 50%. And these patients are at an unfortunate situation that there's currently no standard of care to reduce the risk of uveal melanoma. And when they progress into stage 4, the treatment options are very limited. And the currently approved treatment options are only available to only specific population. That is why we did this study, the phase 2 single-arm multi-center adjuvant nivolumab in combination with ipi in patients with high-risk uveal melanoma that I and my group presented at this past ASCO meeting. So we use the same criteria and we give adjuvant ipilimumab and nivolumab for up to 48 weeks for patients with high-risk melanoma. And when we look at this, we hope to raise the bar of the 3-year distant metastasis-free survival, means that decrease the risk of cancer metastasizing to other places by at least 25%. So unfortunately, we saw an improvement after completion of the study with a median follow-up of 3 years, that we improved the chance of being cancer-free from the control of 43% to 70%. And that is significant with the relative risk of 0.52. And this swimming plot show that, the majority of patients who are on this clinical trial still have an ongoing free of disease. These patients in black are a patient who had metastases either during treatment or on treatment itself. So there are more questions than answers coming from our study, but more study is ongoing. In conclusion from my study, we want to let you know that their high-risk melanoma has treatment option, and treatment option continue to get better, either by surgery followed by different kind of adjuvant therapy, either BRAF MEK inhibitor or the anti-PD-1. And then we talk about the neoadjuvant adjuvant approach that show a promising result to improve the chance of relapse. But it also requires further long-term follow-up. And I think that more clinical trial will come up to find out what is the appropriate option for neoadjuvant approach, and to the point that some of us may think about it, an adjuvant surgery itself instead of like upfront, mandatory surgery in a neoadjuvant setting. And for high-risk uveal melanoma, the current standard of care remain observation. However, the study of the adjuvant ipi will show promising results in reducing the chance of, cancer spreading to the other location. While, we don't really have a standard of care, more clinical trials are coming in the adjuvant or neoadjuvant setting everywhere in the country, and we are a close group of people, close group of physicians. So we have a very, very tight network in here. And lastly, for all of you guys, stay informed, stay positive, and understand your treatment option, and understand that more research are coming. Thank you.
All right, so I have no disclosures. Our objectives today will be to understand the common side effects of immunotherapies, including reviewing and how to manage select immune checkpoint inhibitor toxicities. And at the end, we'll have the BRAF-MEK combination side effects to discuss. Just some general comments on the side effects. We like to identify them early. It's easier to treat and more effectively treat when we can identify early. We do need to exclude other causes, such as infectious causes or other exposures. Treat promptly, taper slowly if the corticosteroids are necessary, and we may need to withhold treatment either temporarily or sometimes permanently during the toxicity management. As you've already heard today, so here's some of our immunotherapies that we have approved. The ones we use in melanoma are the anti-CTLA-4 ipilimumab, and the anti-PD-1s nivolumab and pembrolizumab, and then also the anti-LAG-3 relatlimab, which is used in combination with nivolumab. The side effect profile of these drugs are all basically the same. It's an immune response against normal tissues. We just see them in different frequencies with the different treatments, which I'll get into in a little bit. So the side effects are immune mediated. Most of these are mild to moderate and reversible. Some of them can be permanent, like the endocrine abnormalities, but usually very manageable. Can be life-threatening rarely, which comes into play with how we like to jump on these quickly when we need to. The side effects can affect any part of the body. The more common ones that we see are rash or dermatitis, pneumonitis, inflammation of the lungs, some endocrine abnormalities like the thyroid, inflammation, hypophysitis, and then adrenal insufficiencies, as well as like enterocolitis and inflammation of the eye. So how these, we're trying to activate your immune system to go after the melanoma cells, but in doing that, we can also activate the immune response against normal cells as well, which can lead to inflammation and development of these side effects. The median time to onset can range from days into starting treatment to years. So some people can be on drug for almost 2 years and then develop a serious adverse event that needs treatment. So it can really occur at any point during treatment. This little graph you see on the bottom right, this one I think is from ipilimumab, but we do see most side effects in the first 12 weeks of treatment. But again, this can happen at any point. The most common immune-related adverse events, or IRAEs, as you'll see abbreviated in my slides, include rash, some fatigue, colitis, hepatitis, which is inflammation of the liver, not the usual viral hepatitis most people think of. This is an inflammatory response against the liver cells, pneumonitis, and endocrine abnormalities. The treatment depends on the severity of these symptoms and the grading. We use a grading system called the CTCAE. I have a slide shortly to show you, but we grade each side effect based on the CTCAE grading system. The general management when we need to intervene includes immunosuppression with corticosteroids. So most of these side effects are reversible with steroids. They do require prolonged steroid tapers, usually over about 4 to 6 weeks. and also may require multidisciplinary approach using other teams such as the dermatologist, the GI group, the pulmonary group. So we do consult other specialties when needed. Here are the different grades that we use for the immunotherapies and any side effects. A grade 1 is usually mild side effects, usually asymptomatic or very minimally affected. Intervention is not always needed, but sometimes like topical creams could be indicated. Grade 2 is more, a little bit more significant side effects, usually still pretty manageable, not that bothersome for a lot of people, but usually indicates some sort of treatments like Imodium for diarrhea or topical steroids. Grade 3 and 4 are the more significant side effects that generally require steroid use. So, sorry, this slide here is a summary of the frequency of side effects that we can see. This is across different clinical trials that were done with advanced melanoma. The first column is for Ipi-Nivo. So we do see more side effects in Ipi-Nivo combination compared to like Nivo or Pembro monotherapy. About 55% of patients have grade 3 to 4 side effects, which would require corticosteroid use. About a third of patients did have to discontinue treatment because of the side effects. Nivo and Pembro have fewer side effects or fewer grade 3 to 4 toxicities, about 10 to 15%, depending on the trial. And the combination Nivo-Rela is a little bit more frequent than the single agent Nivo or Pembro, but still less than the Nivo-Ipi. But about 20% of patients needed to go on systemic steroids for side effects. This graph here is showing on the left, you see the ipilimumab or anti-CTLA-4 type toxicities. We see a lot more GI side effects with Ipi, also more side effects in general compared to the single agent anti-PD-1s, which you see in the middle. So the first one I'm going to talk about specifically would be dermatitis or rash. This one is probably the second most common side effect that we see in the immunotherapies after fatigue. Grading is a little bit different with this. We use body surface area in addition to symptoms to grade rash. On the top right picture, you'll see kind of our standard maculopapular rash that can happen anywhere on the body. We see it pretty commonly on the trunk, the torso, or the sometimes in the extremities. Not always symptomatic, sometimes can be pretty itchy for some folks. The way we treat it is we do rule out other causes, like other drugs that might cause rash, like antibiotics, other exposures like poison ivy, etc. So getting a good history is important here, but this is pretty common. Mild grade 1, we can continue the the immune checkpoint inhibitors generally, use oral antihistamines or topical steroids if needed. For more severe side effects like grade 3 to grade 4, these do require holding treatment and treating with like corticosteroids like oral prednisone. So for some more severe reactions, we do tend to give IV steroids in the hospital if needed. That's pretty uncommon. Usually this responds really well to oral steroids when we do need to start it. And then after the rash improves to grade 1, so minor or no symptoms or better, then we taper the prednisone or the steroids over about 4 to 6 weeks. Diarrhea and colitis, we see this quite a bit with regimens with ipilimumab. Can still see it with the single agent PD-1s. Usually patients present with diarrhea or increased frequency of bowel movements. They can have abdominal pain and cramping, some nausea, vomiting. We don't usually see blood in the stools, but it can happen. Usually it's increasing stool frequency and loose stools. When people come to clinic with diarrhea on immunotherapy, we do get stool cultures. We want to rule out other causes of diarrhea, like bacterial, like C. diff, some viral infections that can cause diarrhea, or parasites. We do assess the severity of the colitis by the number of bowel movements per day and the presence of other symptoms like cramping, nausea, vomiting. We do tend to get imaging if it's grade 3 or more, including a CT scan, or with the GI team, we would get an endoscopy and colonoscopy. This is the grading for diarrhea and colitis on the bottom. So grade 1 would be less than 4 stools per day over the usual frequency for patients. Grade 2, we would hold treatment generally if they're on combination treatment, and kind of keep a close eye, maybe delay treatment a week or so and see how things play out. Grade 3 or 4, we do hold treatment and we start corticosteroids pretty quickly. And if people don't respond to steroids, systemic steroids, we do tend to add on another drug called either infliximab or vedolizumab to help control the colitis when we need to. So this is a kind of a nice little chart that we can use for like grade 1, so it's supportive care, use Imodium if needed. You do want to push fluids, make sure people aren't getting dehydrated, and we tend to recommend avoiding like red meats, dairies, fresh fruits and veggies in the short term to kind of give your gut a rest. If it's prolonged, we do tend to get a GI consult involved. For grade 2 or 3, it's going to be hold immunotherapy and evaluate further with scans or scopes, and start steroids when appropriate. Hepatitis, so inflammation of the liver. We screen for this, but we get liver function tests prior to each dose of immunotherapy. If we start to see the liver function tests start trending up, we do tend to get it more often, sometimes weekly, to see how things are progressing. Most patients who have hepatitis from immunotherapy are asymptomatic. We tend to see these changes on the blood work only. However, some people will say, oh, I do feel tired, I have some abdominal bloating or discomfort. And uncommonly, we can see some jaundice, so yellowing of the eyes or the skin, but that's pretty uncommon. We do want to rule out other drug or viral-related causes, get imaging such as an ultrasound if indicated, and do a viral hepatitis panel to make sure this isn't a viral activation of hepatitis instead of an autoimmune process. If we start seeing the liver function test uptrend, we do recommend holding acetaminophen to avoid additional stress on the liver. And we also advise against alcohol during immunotherapy treatment, particularly with the combination treatments where we can see more hepatitis. We can see this in about up to 10% of patients getting monotherapy, but about a third of patients getting combination of IPI and Nivo will develop some level of inflammation of the liver. About 15% of those will have a grade 3 toxicity. This is usually within the first 3 months of treatment. And the grading is based off of the lab values. So if the lab values are 5 times the normal level, that's when we start steroids. If they're grade 2, which is 3 to 5 times above the normal level, we tend to hold treatment and see and kind of trend labs pretty closely and to start steroids if it's continuing to elevate. Steroids, again, are the gold standard for immunotherapy side effects and no different in the hepatitis. And if we have any complications, we do get the hepatology or the liver team involved if necessary. For people that don't respond as well to the corticosteroids, there's a second agent that we can add called mycophenolate, which helps reduce the inflammatory response in the liver and helps us get patients off steroids. But again, this is about 4 to 6 weeks of steroids when indicated. So if we taper too quickly, we can see the side effect come back or kind of rebounds. So we do it slowly. And infliximab, which I mentioned with the colitis, we use for patients that are refractory to steroids. We do not use it with hepatitis because of the concern for liver toxicity. Instead, we would use the mycophenolate. Pneumonitis, inflammation of the lung, happens about 5% of patients on PD-1 drugs. Patients usually can present with a new cough or worsening coughs and new shortness of breath. Decreased oxygen levels on the pulse ox, and possibly some fevers. This can be a little bit tricky to diagnose. It can be confused with pneumonia. It can look pretty similar on imaging. And if we have any concern whether this could be an infectious finding versus a side effect from treatment, we do get pulmonology involved to do a bronchoscopy. The incidence of pneumonitis in the single agent PD-1s ranges about 5 to 7%, so pretty uncommon, but we give a lot of immunotherapy, so we see this quite a bit. Grading is here. So grade 1 would be asymptomatic. We got a CT scan for restaging purposes, and we see some inflammation of the lungs, but there's no symptoms. We can still give immunotherapy. We might consider holding it at least temporarily and see how things play out. Depending on the pulse ox, depending on symptoms, we might do a repeat scan to kind of keep a close eye. But technically, we can still treat, but we do keep a close eye in case we cause the pneumonitis to get worse with further treatment. Grade 2, or grade 3, we tend to hold the immunotherapy and start steroids. And once symptoms recover to grade 1 or better, taper prednisone over 4 to 6 weeks. Again, I said this is pretty uncommon, but we see it quite a bit given the frequency that we give immunotherapy at Georgetown. We do get a pulse ox every time we see patients, just to make sure we have a good baseline. And we have a low threshold for doing imaging on someone that has a new cough or any shortness of breath. We would at least get a chest X-ray, if not a CT scan. The picture you see here, your lung is supposed to be nice and black on the imaging, but these white infiltrates that you see can indicate pneumonitis. They can also kind of look similar to a pneumonia. So sometimes we, if you present to an ER and they diagnose a pneumonia, we tend to kind of weigh in and say you got to think about pneumonitis as well, because it can be a little bit tricky to diagnose. So this is I think I already went over this as far as when to start steroids with pneumonitis. So those are the more common immunotherapy side effects that I wanted to review today, just because those are the ones that we're going to ask about symptom-wise at every visit. And while not immunotherapy, I did want to kind of touch on the side effects that we see with the BRAF and MEK combination, as Dr. Atkins had talked about earlier. So with the BRAF drugs, we have 3 different combinations that are approved, but we can see fevers and fatigue quite a bit with the BRAF drugs, and also a lot of skin toxicities like rash, photosensitivity, itching. Some non-melanoma skin cancers can develop, so we do want patients on the BRAF drugs seeing dermatology closely to evaluate for that. And also with the MEK inhibitors, you can see it's a different appearing rash, but while we can see skin toxicities with both of these drugs, in combination, we actually see less skin side effects when we use the 2 drugs together as opposed to using them independently. We do get lab work on all of our patients whenever we see them to evaluate for any lab abnormalities like liver findings. And for patients that are on the BRAF-MEK combinations, we get routine cardiac evaluations like echocardiograms to assess for any decreased ejection fraction or any changes in your heart's ability to pump blood. And that's usually every 3 to 6 months. And then here are the 3 approved drug combinations and just some of the kind of pros and cons to each. But with the Dabtram, we see a higher rate of fevers. But we do manage side effects with the BRAF-MEK drugs differently than we do with immunotherapies, because this is not an immune response causing the side effects. Usually a drug hold is sufficient. And then if you have fever, starting like acetaminophen or ibuprofen would be indicated in the short term. With the VEMCOV, we do see a higher rate of photosensitivity. So patients on these drugs need to be very careful in the sun, using good sun protection, sunscreen, the UV shirts. And then the ANCO-BINI, we do see lower rates of both the fevers and the photosensitivity. So that was just a really quick synopsis of the BRAF drugs. But in summary, the key to toxicity management is communication with your team. We always tell patients that we want to hear from you. We'd rather hear from you than not. Even if it's minor, reporting side effects in between visits is important, so we can kind of determine if we need to see people sooner than they're scheduled or intervene faster. Again, side effects can happen at any point during or even after treatment. So people can be off drug for several months and still get immunotherapy-related side effects. It's easier to treat toxicities early. They do resolve quicker with early interventions. It's important to report these things so we can intervene when necessary. And again, the majority of these side effects are reversible with appropriate management. Some of the endocrine abnormalities or endocrinopathies, it's more of a long-term issue, but usually pretty easy to manage with appropriate drugs. And then depending on toxicity, treatment may be restarted depending on time to improvement and how well you responded to the corticosteroids. So again, notifying your team of any new or worsening side effects, even if mild, is going to be key. And I think that's all I have.
Great. Well, thank you, Kelly. Quite a comprehensive coverage of a lot of the immune side effects that we can see, as well as looping in the targeted therapy that we often use in the clinic. Well, thank you everyone for the attention. This is a great symposium for us to present current standards in management and data on melanoma, as well as the future directions. So I have the privilege of talking about our current research, some of the new developments, cell therapy, and where we think the field is heading. These are my disclosures. So as an outline, I've picked three different categories, three topics that I really thought would be important for a discussion with a patient audience. And the first one is, when can you stop your immunotherapy? And this is going to be centered around some of the research we've done at Georgetown, as well as a national study that we lead called the PetStop trial. There's also been a lot of data that's come out on personalized cancer vaccines and melanoma. And we get a lot of questions of, when is it appropriate? What type of patient would it be best in for melanoma? And we're going to try to dive into that. And then the last topic, which is very exciting, is the new T-cell based therapy in melanoma that's coming out. And we certainly have seen a lot of development for immune checkpoint inhibitors, as Dr. Atkins and Dr. Epsoon brought up. Where that doesn't work, we think this is the future of immunotherapy for melanoma, probably as well as other tumor types. So Dr. Atkins already covered this, but just to kind of bring it back to our attention, we currently use immune checkpoint inhibitors for our immunotherapy in melanoma. These are antibodies, and they block pathways that suppress T cells, immune cells. These are the immune cells that would attack the cancer. So all we do is block these pathways. One is CTLA-4, that's the drug Yervoy or ipilimumab, and then the PD-1, PD-L1. Those are the drugs nivolumab, Opdivo, or pembrolizumab, Keytruda. When we block them, we reactivate or reinvigorate T cells. And those T cells already know what to do in many cases. They will attack the tumor. And if we're successful, we can clear the tumor. And the data has shown that giving 2 drugs is better than giving 1, that when we combine drugs like nivolumab and ipilimumab, we can see response rates over 50%. And the vast majority of those responses are very durable or even permanent in many patients, we think. So where does that leave us, though? We have seen long-term follow-up from some of our studies. This is data from what we refer to as the Checkmate 067 study, where nivolumab was combined with ipilimumab. And then there were 2 other arms that were single agent, the nivolumab and ipilimumab. And what I wanted to point out here in this long-term follow-up, you can see 90 months out, where most patients, or really all patients, are off treatment at that point if they have not seen a progression, is that the survival looks, in my opinion, incredible. That over half of the patients are free of melanoma and doing well, alive years after treatment. And you can see here that we do get a higher survival rate for melanoma-specific survival with the combination nivolumab, ipilimumab. We've been offering this treatment in our clinic for over 8 years now, as on trials, expanded access, and then standard of care. And this is what we've seen in our patient population, I would say, is that we have many long-term survivors doing very well. After completion of treatment, they've been followed and have gone on with their lives. And as Dr. Atkins refers to them as thrivers. The unfortunate scenario is that that's not everyone. As you can see here, about half the patients do need other therapy. And there is plenty of room for development, and this talk will cover both sides of that. So when patients are responding well to their immunotherapy, when can they stop? Patients who have serious side effect, as Kelly Gardner was bringing up, that's sometimes an easy decision. We just can't give any more of it, and hopefully they respond very well. But in patients who are responding and do not have a serious toxicity, serious side effect, when can they safely discontinue their immunotherapy, their anti-PD-1 drug, after having a response? We know that in the side effect patients, those who had serious enough side effects that they had to discontinue their immunotherapy, in this data set, it's nivolumab, ipilimumab, they did quite well without any further treatment. And the median, so half the patients stopped treatment within 1.5 months. So this is a very short duration of immunotherapy. And the response rate was still as high as the patients that didn't have to come off for toxicity, that it was over 50%. And we saw that those responses continued despite not continuous dosing of the drugs. So this taught us that there are patients that can get short durations of treatment and have great responses, and those responses can be durable despite coming off treatment. The survival curve off to the right shows you that in the blue versus the yellow or orange, depending on how your screen is, that the survival curves look very similar, those who came off early for side effects versus those who did not. So we think that there's clearly patients that get most of the benefit up front, but what is that optimal duration of treatment? And is it the same for every patient? In the clinic, we see some patients have very quick responses to the treatment. We see some patients have late responses, and even sometimes where it looks worse before it gets better. So it's probably not one size fits all, and it needs to be a tailored approach. What we've been doing for a while now at Georgetown is looking for active disease after patients have been on treatment for about a year. And one of the tools that we've used is a PET scan. And this is a type of scan you can look for tumors, both identify if they're there, the size of them, and then the activity. That's the brightness that we see on the scan there. This is a patient that I've treated at Georgetown that had metastatic melanoma and tumors that were in the chest area outside of the lung called the mediastinum. Those are the bright areas with the red circle. And then also had tumors in the spleen. That's the blue circle there in that pre-treatment. And you can see these are fairly sizable tumors, and they also have a lot of activity. They're very bright on the PET scan. And after a year of treatment, we can see tumor shrinkage in this if you follow it to the right. And the brightness has diminished. So the activity level looks like it's gone down, but there still is some activity level being seen. What we don't know is if that's tumor or if that's the inflammation, the immune system attacking the cancer. And what we have offered to patients in this scenario, if they are interested in trying to come off therapy, is to look to see if in these spots, if you put a needle in it and do a biopsy, is there any residual cancer? And what we've found quite often is in a patient like this is that you really find no active cancer. And what you're looking at on a PET scan after the 1 year of treatment is really just the residual effect of inflammation as the immune system attacked the cancer. In patients where we've found this, we've had discussions whether they should continue treatment or not, and a lot of patients have elected to discontinue therapy. We've now been working with quite a large panel of patients in melanoma where we've actually been through this stepwise process, and we've collected our data. It's all retrospective, but we looked at the outcome of patients who electively came off after we could not identify any active disease after 1 year of treatment. And what we saw is that when those patients decided to come off treatment, that's that green curve on this survival figure, that their outcomes were quite good, that very few patients actually progressed off treatment, and the survival at the 1-year mark was over 100%. We did see a couple late recurrences, 2 in this group of patients, but we would expect that in patients in general, even if you stayed on treatment. So this, in our minds, looked as good as it would if patients stayed on treatment, and there's a lot of benefits of actually being off treatment. And as a comparison, these patients were doing better than those who were responding and came off early due to toxicity. That's that purple curve. Numerically, there was no statistical difference, but you can see that both groups were doing very well. This led to Dr. Atkins and I working on a national study within the cooperative group system, the ECOG-ACRIN system, where we now have a phase 2 study of biomarker-driven early discontinuation of anti-PD-1 therapy in patients with advanced melanoma. This is called the PET-STOP trial. So we're hoping that the approach we've been using will become a standard approach in patients with melanoma, but we need to have a little bit more data to verify these really good outcomes that we've seen at Georgetown. And the hypothesis is that in advanced melanoma, patients with response can safely discontinue anti-PD-1 therapy after 1 year of treatment if there's no residual disease seen on a PET scan, or if you do a biopsy on the pathology report. The study is designed that if we are successful, hopefully this will become standard of care. And there's clear benefits if we're able to achieve this, where patients will come off therapy early and hopefully avoid late adverse events or late side effects. It'll reduce the cost of care. Patients will get less treatment, less frequent visits to the clinic, and less risk of being hospitalized, and in general, a better patient experience. On the other side, we hope we'll identify patients that are high risk for recurrence, and it'll hopefully expand to other tumor types. So there's a lot that we think that will come from this research, and very exciting that Dr. Atkins and I can help lead this way in this effort. And to switch gears, wanted to also focus on that other half of patients that I alluded to that do not respond well to their immune checkpoint inhibitor, their standard immunotherapy in melanoma. And I put up this figure as sort of just food for thought for us, and understanding how our immune system recognizes and attacks cancer. In the academic world, we refer to this figure quite often, but I just wanted to kind of throw these general concepts up. Is when our immune system is exposed to tumors, there's antigens, these are small proteins from the tumor. Our immune system will pick it up. That's going around the wheel from 1 to 2. And when it does pick up those small proteins, those antigens, those immune cells will then stimulate responses and activation in a population of T cells. These are a specific type of immune cells in our body. And these T cells are really the soldiers. They can go off, traffic to tumors. They have a way of migrating through the bloodstream and finding their way to melanoma tumors as well as other tumors. They can recognize them. That's as we get to number 6. And then when they engage those tumors, they hopefully will kill them off. And we know this happens every day of our lives. Otherwise, as our cells replicate and divide, we would have cancer more often. Unfortunately, this process does fail, and that's where we develop metastatic disease. And our therapies target different aspects of this cycle, this immunity cycle. And what we now do is we develop strategies at certain points in this immune cycle, trying to make our immune system more effective, more active against the tumor to overcome resistance. And one of those strategies is on the vaccine side. So we're trying to teach our immune system to rev it up, to go after the tumor cells, using the patient's own immune system that is in place. We've now seen data presented for what we call personalized cancer vaccines. This is the new development from a company called Moderna. Most of us are now familiar with this company as a COVID vaccine. But before that, this company was making cancer vaccines. And Dr. Rapasuan have put up slides on this data. We've been involved in this research at Georgetown, and it's been very exciting. This is a recent publication that was presented at ASCO last week. And the idea is that we take a patient's tumor, we sequence it, we identify the genetic changes that are in that tumor that are unique to that tumor, and we can vaccinate against it. And those vaccines are small, it's an mRNA, which are converted to protein, but that's unique to the tumor. So when we're vaccinating a patient against their tumor, we're stimulating an immune response that will hopefully only attack the tumor cells, not the rest of the body. And this is specific to the patient's tumor. So you could not use one patient's vaccine for another patient in this scenario. It's very specific to that individual's tumor. And the figure off to the right is a little more technical, but once you inject it into a patient just under the skin, it gets taken up into the tissue and your cells identify it and process it. And then once your cells process it, it then trains the T cells what to go after, what to look for, and heightens a T cell response against the tumor. In this randomized study, it was a phase 2 study that we have open at Georgetown, actually reopened because they added more patients to it. This is for high-risk patients with melanoma after surgery. They would be randomized to either the vaccine plus pembrolizumab versus pembrolizumab alone, which the pembrolizumab is the standard treatment we offer most patients. We found that it reduces the recurrence risk, at least in this study. And it was a significant reduction by almost 50%. You can see in patients that got the vaccine plus pembrolizumab that the recurrence-free survival, that's that red line, was quite high, that we saw at the 30-month mark that roughly 75% of patients were still recurrence-free. And that was a 19% difference from patients that just got pembrolizumab alone. We have to keep in mind, pembrolizumab does a really good job at reducing recurrence, by about 40% reduction. So to see a gain like this is really hard to show with any drug. So this is very exciting for us, and we hope that this data can be replicated. And it's now part of a registration trial, a phase 3 trial trying to gain FDA approval for this vaccine. Fortunately, the vaccine is pretty well tolerated. It's like getting, I would say, on average, the experience like a flu vaccine or maybe even the COVID vaccine. And this is something that we dose up to 9 treatments during the course of the year that the patients are getting the rest of the immunotherapy. I get the question often, can we use this for stage 4 patients? Would this type of strategy help with the immunotherapy that we're giving patients such as nivolumab and nivolumab ipilimumab? And the data has not been very convincing so far, I would say. So the other COVID vaccine maker, Pfizer BioNTech, also was making tumor cancer vaccines before they were known for COVID. This is a study that they were involved in with a personalized cancer vaccine, and their immunotherapy agent was atezolizumab, and it was given to patients with a range of tumor types, not just melanoma, although melanoma patients were included in this study. We were involved in this study at Georgetown, although it was a very large study across the nation. And what they saw is that the vaccine did stimulate T cell responses against what was being vaccinated, the tumor, but the response rate, unfortunately, was not as high as we had hoped. And if you're familiar with looking at waterfall plots, each bar here represents a patient. And what we hope to see is that the bars are pointing down, meaning the tumor burden decreases. And you can see here that the tumor burden did decrease, but only in a few patients. And it's not clear if in some of these patients it would have been just the atezolizumab, their immunotherapy agent, or if it was the combination with the vaccine added. And I think when we saw this data, there was concern that maybe the vaccine strategy in stage 4 active disease patients may not be as effective. We might not see as much gain as we would see in the adjuvant setting where the tumor has been removed and we're trying to prevent recurrence. So we have to, though, really see this in confirmatory studies. So the first study I have here listed is that adjuvant Moderna study. That's the personalized cancer vaccine trying to prevent recurrence with pembro. And that's an ongoing study and hopefully will lead to approval. The BioNTech study in melanoma, using that vaccine that I just showed on the last slides, with Pembro has been an active study that we haven't seen the data for yet. So we are waiting. That's the second line. And there are also other vaccine strategies that are ongoing. We haven't seen the data yet for some of it we have. But it may be that some of the vaccine strategies, the newer ones, do not need to be personalized. They can be off the shelf, something that's the same product that's given to each patient. And you can see a few companies between BioNTech, Scancell, and IO Biotech are working on that in melanoma. So hopefully there's more to come with this. Going back to our cancer immunity cycle, one of the other areas of recent development and really a breakthrough, I think, in treatment for melanoma is T-cell therapy. And it works on the other side of the immunity cycle and really bypasses some of the deficiencies and some of the limitations that may exist with some of our immunotherapy strategies. And we now have new classes of therapies coming out. You'll hear the term tumor infiltrating lymphocytes or TIL therapy. These are specific cells that are collected from a patient's tumor that when grown in the lab and given back will target the tumor. And then we have T-cell engagers. These are drugs given intravenously that hijack, basically bind to patient's T-cells or immune cells, and then repurpose them. We then force those T-cells to go after the tumor. And there are other types of T-cell based therapy. I have it here in grayed out because that's for another day and another discussion. We're going to focus on the first two. And what I just wanted to point out to our audience here is that when we do a biopsy or when we remove a tumor, we see a sheet of cells most often. That's that H&E figure there. And that's basically cell to cell, just covering the sheet of the slide there. What we know, though, is that it's not just all tumor cells. There's other cells mixed in there. And that CD3 and CD8, those are stains. Those are markers that are on immune cells, specifically T cells. And if you look for it within that field of tumor cells, you actually see that they're mixed in with it, that there are immune cells hiding in the tumor, that they've actually migrated into that tumor trying to respond against the tumor. And a lot of times they're stalled out. We see this quite often in melanoma as well as other tumor types. And these are what we call tumor infiltrating lymphocytes, or TIL. The new therapy strategy is not actually that new. It's been really an ongoing work for the past almost 40 years. And the basic principles are where you excise a tumor, you digest it in the laboratory, and you grow the T cells. You test the T cells to ensure they recognize the patient's melanoma. And then if they do, you expand them. You go from thousands to billions. And once you've gotten to that point, you then have a plan to administer them to the patient as an IV infusion. It does require a patient to get chemotherapy beforehand to temporarily stun the immune system. It brings down the immune system. So when you infuse these cells, there's no rejection or competition. And then we do stimulate after the infusion of the cells with a drug called interleukin-2. That helps them expand and target the tumor at a higher efficiency rate. And this sounds like science fiction, or sounds like it's something that it would be really hard to do, but it's been done since 1998. Actually, before that, the first publication was 1988 by Steve Rosenberg and colleagues at the NCI. And this is, as you can see, even before we were conventionally doing CT scans, that in this diagram here of a patient receiving TIL therapy on chest X-ray, you can see that those tumors at the lower part of the lung fields basically melted away in this example. They reported on 20 patients treated and had a response rate of somewhere between 40 to 60%, which at that time was unheard of. And this has really led to further developments, although slowly over time, because this is a very technically challenging type of therapy to develop and to dose for patients. Fast forward 30 years, and it's now been commercialized. And one of the companies, Iovance, has developed this as a commercial product and has conducted multiple studies. This is one of the studies that they were able to achieve registration or FDA approval for their TIL product. That's called lifileucel, their T-cell product. And it was studied primarily in patients with melanoma who had progressed through their standard immunotherapy, and if they had a BRAF mutation, progressed through their BRAF therapy. And the data here is that cohort 2. They use that standard approach where you cut out a tumor, you grow it in the laboratory, the white cells, and then you bring back the patient for their chemo, their T-cell infusion, and IL-2. They showed that they could grow the T cells in about 22 days, which was quite a remarkable feat. And they are trying to reduce that time and hopefully will be able to do that. And in this group of patients, they showed that it worked in at least a third of patients where you had very dramatic shrinkage of tumor. The responses look durable, so we do expect this to produce long-term survivors in patients. We're very hopeful based on the data we have. And not only that, you can see that patients who didn't have dramatic shrinkage often still had tumor shrinkage. So it probably is a much higher percentage of patients that are getting benefit than just that 36%. There are a lot of side effects that can happen. Basically, every patient will have at least one somewhat serious side effect, but they are very manageable at specialized centers. Most often, the blood counts will drop. You can get fevers. You can have low blood pressure. You can have fast and irregular heart rates, but these are managed in a supervised setting. In our center at Georgetown, we do it in our transplant unit in ICU if we need to. The first patient we were able to do TIL therapy for was on a trial, an Iovance trial in 2020. This is a picture of the actual tumor that was removed. You can see it's very small. We do not need much tumor. The target is around 2 centimeters of a tumor that can easily be removed. And this is some of the research team members. It's looking kind of serious, actually, shipping off the first tumor to Iovance for the manufacturing process. It was very exciting. Now this has become pretty routine. And it's a pretty streamlined process where the tumor is shipped off to the manufacturer and then shipped back to us to dose the patient. This product, lifileucel or Amtagvi, is now FDA approved and it's available at Georgetown, which is very exciting for us. There's a lot of new strategies in melanoma T-cell therapy that are being developed. We have one of those strategies open as a trial. That's the Lyle 845 trial, where they have a different process for manufacturing for growing these T cells. But it's also an area of active research in different directions, where we know TIL therapy is being studied as a frontline therapy with some of the Iovance work. There's a group that has designed their way of manipulating the T cells so it doesn't require the IL-2, which looks very exciting. And then there's also another group that's further engineering the cells they collect to go after specific targets. And in this case, it's PRAME. That's a protein that's on tumor cells. And we've seen some exciting data for that as well. So this is an area that's going to expand very quickly in the future. And in the last just minute, just wanted to bring up an area that is hopefully taking us into a more practical way of doing T-cell therapy, where rather than collecting cells from a patient, we leave the cells in the patient and we give a drug that repurposes the T cells. This is an example of what we call a bispecific T-cell engager. That red circle is a kind of trying to highlight where that drug is. And it has two ends, one that will bind to the T cell, that's that CD3 end, and then another end that will recognize a protein that's being presented off of the tumor. So you basically bind to your T cell, and then you have the ability to recognize a tumor cell, and it will traffic the T cells to the tumor specifically. And when it has that engagement, we anticipate that those T cells will attack and kill the tumor. And we know that this can happen. This strategy has been developed, and there is an FDA-approved drug called tebentafusp for uveal melanoma, which is very exciting. And this slide here is with a slightly different version of this strategy called brenetafusp, going after PRAME. And we saw data presented at ASCO last week that looked really exciting for this PRAME-targeted bispecific in melanoma. And we saw that it reduced the tumor size in about a third of patients, dramatically in somewhere between 11 and 13% of patients. This is an area where they're trying to identify other ways to monitor patients because the scans seem to underrepresent the benefit. And what they've also seen is that if you look for a tumor in the bloodstream, that's the tumor or circulating tumor DNA, you can see it fall pretty dramatically in about half of the patients that are treated with it. And in this waterfall plot, where you can see that each bar represents one patient with the drop in the tumor DNA in the bloodstream, was very impressive. And this hopefully will lead to further studies and better patient outcomes as we're able to offer this type of therapy for patients. This company is planning, this is Immunocore, is planning a frontline trial where this drug, this brenetafusp, is combined with nivolumab. And it's a randomized trial where it's going to be patients in the control arm that get standard of care immunotherapy. We're very excited about this trial. We're trying to open it at Georgetown. Hopefully at the end of the summer would be our target, but we're looking forward to seeing this, being able to offer it for patients. So to conclude, immunotherapy produces durable off-treatment survival in patients, and now it's time to determine when it's safe to discontinue treatment. The personalized cancer vaccine shows significant promise in reducing recurrence of high-risk melanoma. And in half of the melanoma patients who progress on standard anti-PD-1 therapy, T-cell-based treatments are a newly emerging effective treatment option and clearly changing the field. So I'm going to stop there and thank you for the opportunity to present and talk about this exciting research. I'm going to hand off the baton to Mike Atkins, Dr. Atkins, to lead us into the panel discussion.
So thank you to the presenters. I encourage everybody who presented to open your camera and your microphone. And we're a little bit over time, but I encourage the people watching to stay on so that we can answer some of the questions that are here. And joining us in the panel will be Leonard Ellentuck. Leonard, can you turn your camera on? He's an oncology social worker at Lombardi Comprehensive Cancer Center for the last 18 years. And he's certified in oncology social work and palliative care, and has been helping us and our patients and navigate difficult challenges and decisions that they face during all phases of their melanoma treatment. So he's here also to answer any questions you might have about the patient journey. So we do have a few questions, and I'll direct them to people. So there's a question about what were some of the key melanoma findings from ASCO 2024. I think we've talked about them, but Dr. Gibney, do you want to just quickly summarize them? I think they were presented by all four of us, I believe.
Sure. So I had a couple slides in my slide deck, which one of them was the personalized cancer vaccine showing continued improvement in reducing the recurrence-free survival. Very exciting, although that's still a research strategy. The T-cell therapy strategies were a part of the ASCO presentations. One of the presentations by one of the series of slides that Dr. Rapasuan presented was the NADINA study. That's where we're giving drug up front for palpable stage 3 melanoma. And it looks very clear that this is the strategy we should be offering for most patients, where we give immunotherapy before removing the tumor when we can, both to learn from the response, but also improving the outcome for patients and potentially de-escalating the amount of drug and surgery we do afterwards. I think those were the main highlights. Dr. Atkins and Dr. Rapasuan, maybe there were others that you thought were important for us to bring up here.
I would also mention the triple therapy of data that it's safe to give anti-PD-1, anti-CTLA-4, and anti-LAG-3 together, and the promising results of that, potentially leading to better upfront immunotherapy. Dr. Rapasuan, anything you wanted to mention beyond that? Of course, your melanoma work, uveal melanoma work.
Yeah, of course. In that area, rare melanoma, we have gone quite a long way from 0 abstract to 3 different abstract using treatment for metastatic uveal melanoma, adjuvant, even neoadjuvant approach, although preliminary. But it's still quite uplifting to see advancement of the field and the enthusiasm from the whole world community. Yeah.
So another question, this is for you, Kelly. Is there a protocol for clinics to use for adverse events and for managing them?
Yeah, I mean, we do use like the NCCN guidelines for managing side effects, but we use a grading system to determine what the severity of the side effect is, and we based off our management based off the grading. But we do,
And
there
I
are
would just, go
okay.
ahead, keep going.
Oh, no, there are several resources that we use for guidance if needed, including like the NCCN guidelines.
Yeah, and there are guidelines by Society of Immunotherapy of Cancer, ASCO, American Society of Clinical Oncology, and ESMO, the European Society of Medical Oncology. So there are a lot of guidelines for us to follow. We've been involved in drafting those guidelines, and they've become pretty commonplace, especially since these immunotherapies are used for only over 20 different types of cancers and almost 30 indications. Our clinics that use immunotherapy required to keep track and report adverse events. Kelly, do you want to take that too?
Yeah, so I mean, for standard of care, I don't think we have a formal documentation process as far as outside the patient's charts, but for clinical trials, we certainly document every side effect, every grade, and every attribution that patients may have while on a study.
Dr. Gibney, do you want to chime in at all?
I would agree with that. When we do see unusual side effects, those not captured in the clinical trials, there is a reporting pathway that we can update the FDA and the maker of the drugs, and we sometimes are asked to do that. But in general, we are expecting to see some of these side effects and manage them, and that's just the way we practice.
Great. And Leonard, can you just give us a couple of minutes discussion about some of the things that you do to help patients along their journey? You might still be muted. Can't hear you. Maybe turn your volume up on your microphone. Oops.
Thank you. Can you hear me now?
Got it. Yep, perfect.
I'm sorry, you wanted me to comment on
Some of the things that you do to help patients along their journey.
it's, people ask me frequently, what does a social worker do? And the answer is both general and hard to render because it's not certainly not one thing. There's a variety of things. I think what I can say, besides, a social worker's job is to enhance treatment with the non-medical issues, getting them to their appointments, identifying or responding to obstacles that might hinder treatment or their well-being. It can be mental health issues. It can be not having enough to eat. It could be having financial and insurance issues, although I'm not a financial or insurance counselor, but frequently called upon to address what is holding people back that might interfere with treatment. And, with the sort of basic prerogative of wanting to just people to be healthier and better in every way and happier. But in this context, it's very much around helping them access their cancer treatment. So it can be things as simple as transportation to appointments, although now we have a transportation coordinator who's allowed us to sort of use our skills in more areas more tailored to our actual skills and experience as social workers. And it's also can be coordinating care. There's a person who knows them from inpatient to outpatient, who's familiar with their situation, who can get them in touch with their doctors and nurses. I mean, Dr. Atkins and Dr. Gibney are very fortunate to have Kelly and their nurse Helen, who are so very skilled and able to help with these things. But I try to also be part of that communication team of keeping in mind what a patient's issues are and how we can best help them, and when we can't help them too. So that's, I want to say in a nutshell. I'm happy to answer more questions, but that is a synopsis of what I do, or we do as social workers.
Great. So I don't see any more questions. There are a couple more very nice comments in the chat, but in the absence of other questions, I'm going to turn it back over to Dr. Gibney for closing remarks.
Well, thank you, Dr. Atkins, and I want to thank everyone for staying on. We acknowledge that we are running a little bit over what was our planned timeline, but I think we covered a lot of really important topics, very exciting developments ranging from the diagnosis of melanoma, prevention strategies. It is still fascinating that we see more melanoma, but we are seeing a lot of patients do much better. So this looks like this is a growing concern that hopefully will peak. And with intervention strategies, we will see prevention strategies. This will really slow down the incident rate through efforts like we saw earlier with the Tanning-Bennett interventions. We still need to identify patients at high risk for melanoma. We're doing a much better job taking care of them, but we, I think, still have room for improvement identifying patients that after surgery will relapse and need the adjuvant therapy, the therapy that lowers the risk of recurrence. And we think there's plenty of development that is in our future for that. The standard treatments keep evolving, whether it's to prevent recurrence or to treat active disease. The major advances have greatly improved patient outcomes. The data shown by Dr. Atkins, where stage 4 survival historically was 10%, now it's well over 50% in the long run. But we have more room to grow. That's where our research focuses are at Georgetown. We're really excited about these developments and making sure that we have the opportunity to offer it to our patients and be part of the process. With that, I'd like to thank our participants for spending your Saturday mornings with us talking about melanoma care and advances. I'd like to thank our panelists for some great presentations and the education, and to thank our Melanoma Research Foundation organizers for making today's patient symposium possible. With that, I would like you all to have a wonderful rest of your weekend, be sun safe, and we look forward to seeing you soon.